Okay, the webinar is now live. Okay.
I gotta change my name.
Murray's a fine name.
It says Maureen Malik.
That's a fine name too. It just happens not to be yours.
Changed it for you.
Oh, I just did it. Oh, thank you. Oh yeah, you got it. Thank you. Hi, Bridget. Hi, everybody else.
Good afternoon or morning for our Pacific Coasters.
Thank you.
Murray, I have slides. Do you want to kick off first or do you want me to go first?
I do not have slides, so why didn't you go first? I could just say hello. You go ahead. You go ahead. I don't.
Sounds good.
You go ahead.
Sounds good.
Why don't we give attendees about 2 more minutes to trickle in, and then we could get started?
Yeah, that'd be perfect.
Okay.
All right, Bridget, should we start?
Yeah, you read my mind. I was just going to say the same. To
you
stay
see-
on time, kick
Can
off.
you see and hear me okay?
Yep.
Okay, so we're going to get started if everyone's okay. First of all, I'd like to kind of, on behalf of the Vascular Surgery Board and the Association of Program Directors of Vascular Surgery, kind of welcome you all and thank you for taking the time out to, as far as our initial Vascular Surgery EPA retreat. I'd like to give a special shout out to our guest speakers, Rebecca Mender, George Cirosi, Vanessa Lindemann, Jake Greenberg, and April Broyd. And this has really been a combined effort, but I must give the largest kudos to the APDVS, who has really put all this together under Murray Shame's leadership. Bridget Smith and Faisal Aziz have really done a nice job, and they get all the credit for this. The way we thought we would start this out is that I would give some brief comments about where the Vascular Surgery Board stands on this, and Murray will talk a little bit about the APDVS, and then we can kind of launch into the meat of the day and the meat of the presentations. Fairly briefly, and I apologize in advance if I overlap on any of the concepts during my few slides. Joanna, how do I switch that?
Just click your mouse.
Okay, there we go. Can I go back? Okay, there we go, perfect. Yeah, so where does the VSB stand on the EPAs? Okay. Can you back me up one? There we go. There. Where does the VSB stand on the EPAs? I think there's a recognition across the board of the importance of the EPAs and the appreciation really of the magnitude of the effort that's going to be required to pull all this off. That recognition requires really the integration of all the stakeholders, primarily the APDVS. Most of our efforts over the past year have been put on hold given the virus, and I think the major focus of the VSB was the certifying exam and the qualifying exam. But as things have abated a little bit, if you will, we refocused in the last 6 months on the EPAs, and there's been some dialogue between our organization and primarily the APDVS, and this effort is really the initial more global effort in terms of move this effort forward. I think the implementation of the ABS is really a priority. Implementation of the EPAs is really a priority of the ABS, and I think we have the opportunity to build on what the ABS has already done, particularly in terms of general surgery, one of the other component boards. I think there's an appreciation across the American Board of Surgery that some type of residency redesign is necessary. The current system of curriculum and assessment may not be providing us with the optimal end product. You know, I think moving forward, we have the opportunity to be more efficient, but really improving the end product is the primary goal of all our educational efforts. Competency-based education is really the new iteration where the focus is on the outcome of education. Training is based upon achieving a certain level of competence, and the general principles should really be a same or minimal level for all. It's, I think, understood that this may result in variable time to completion for the various process based upon the individual learner's learning rates. It really, the EPAs is really the next iteration. It kind of puts things all together. You know, we've gone from the milestones to the competencies, the domains of competence, and now the EPAs. A few years back, the American Board of Surgery set up a pilot study for the EPAs in using general surgery. The purpose of that pilot was to assess the feasibility of EPA-based assessment in somewhat diverse training programs to assess the impact of the EPA assessments on the ACGME milestone completion. The study design was such that it was a 2-year longitudinal multi-center pragmatic trial of EP-based micro-assessments on decisions about summative entrustment and milestones, and the data collected including the number of assessments, summative entrustment, confidence entrustment, and the milestone data. That study's been completed and published, and I think the lessons that the board learned is that EP assessment is surgical training is feasible, some type of smartphone technology is necessary, and the clinical competency committees are key to the entrustment decisions. In April 2020, the American Board of Surgery directors, took the initiative to that there will develop a set of EPAs for general surgery. Once again, one of the other component boards, identify or develop software tools to support the EPA, develop faculty and resident toolkits for the EPAs, with the goal really being that the EPA assessment should start with the class entering 2023, albeit somewhat aggressive. And the board has encouraged the other component boards, us, to take the initiative and implement EPAs. The structure of the EPA project for the American Board of Surgery is that there will be 2 councils, an advisory council and a scope council, and 4 work groups, including a revision work group, best practices work group, technology task force, and a writing group. The ABS Council is really charged to define the final set of general surgery EPAs. It has very broad representation from the General Surgery Board, the various component boards, and I serve as the VSB representative, the APDVS, the Fellowship Council, the RRC, and the separate colorectal board. The EPA writing groups will be responsible for the actual creation of the EPAs, the descriptions, essential functions, scope, and expected behaviors. And this group will kind of work in dyads to write 2 EPAs each. The number of dyads will really be defined by the number of total EPAs identified, and the expectation that there will be very broad representation in the EPA writing groups, including members of the APDVS, residents, and the various component boards. The scope timeline is such that we had the initial meetings in February 2021. We're defining the EPAs now. The goal is that the topics will be selected by December 2021. The writing groups will complete their part by June of 2022 with a further review by our organization and final implementation or completion of September of 2022. Effective next week, I will become the chair of the Vascular Surgery Board, taking over from Gib Upchurch, who's really done a yeoman's job over the past 2 years. And this is one of the agenda items that I would like to push through. From my perspective, this is not a VSB or ABS perspective, vascular surgery is perfect for EPAs. It's really what we do all day, every day. When someone calls you to say they have 2A or 2B ischemia, whether you trust that individual. Do you have to come in and see the patient, or you feel safe booking them for the operating room? I think my goal is to try to keep this simple to the extent that we can. If you ask me what I am, I'm a clinical vascular surgeon, not a professional educator. It's really simple to say, can they do it or can't they do it? And I think we should try to be as simple as possible throughout this whole process. I think development is really going to require a combined effort of all the stakeholders, the VSB and particularly the APDVS. And I think it's really practical to build upon what the board has done with general surgery so far. You know, we in vascular surgery, the reason I think this is ideal, we only do 5 or 6 different things. We take care of aneurysms, we take care of occlusive disease, we take care of cerebrovascular disease, venous disease, dialysis access, mesenteric and renal disease, and perhaps to a lesser extent tertiary care, but that may not be appropriate for an EPA. If you think about dialysis access, what are potential EPAs? Access creation, management of failing or thrombose access, management of complications. It can be relatively simple. So that's what I wanted to share, at least for the board perspective. I'm anxious to hear Murray's thoughts on the APDVS, and then we'll get into the meat of the afternoon.
You know, a year and a half of Zoom and you still can't unmute automatically. Thank you, Tom. And again, I want to reiterate a thank you to Bridget, Faisal, Joanna, and the team, and to all our speakers. We really do appreciate you taking your time today and helping us get to where you are, because we are starting out a little bit behind the 8 ball. From the APDVS perspective, and I am not as organized as Tom and have slides, but I do have some thoughts. You know, we've spent some time, and my predecessors at the APDVS have, you know, we've really worked hard to try to reorganize how we do our education, how we do our assessments, how we give the content back to our residents, with a complete overhaul of our curriculum, going to V-score, really focusing at our meetings the last few years on educating our members on how to do assessments, how to give feedback, how to really be good educators. But we don't have the infrastructure to do that. And we also don't really want to reinvent the wheel. You know, and so as Tom said, we have straightforward plumbing operations, and they should be easy enough to assess whether somebody can do them or not. We have implemented the fundamentals of vascular surgery and fundamentals of endovascular surgery, which are basic skill assessments to sort of identify the skills component of basic suturing. But we really don't need to work on judgment and putting that suturing skill together with planning and delivering an operation. So I think this is really important. The other thing that's important is our members, as well as our residents and fellows, have asked for better feedback, and I think our current assessment, you know, end of month evaluation just doesn't do justice to the ongoing feedback that they need and the documentation of that feedback. So again, what I'd really like to do is learn from all of you who have done this. You know, anecdotally, I'm working with another specialty group on some training guidelines, and I brought up the word EPA, and none of them had even heard the letters. So I think, you know, we want to make sure we fully understand what an EPA is, understand from you all how we go about designing them and doing them well, and what we should be doing, and then how to implement them. So that would be my goal today. And I thank everybody for participating, and thank you, Tom, for that great intro.
Awesome. Thank you, Dr. Huber and Dr. Shames, for getting us kicked off this afternoon. Just a couple words about the format for the afternoon. In an effort to respect all of our speakers' time, the format is that each talk will be followed immediately by Q&A, so that speakers are able to leave and get on to their busy practices if needed, as opposed to a panel at the end of the afternoon. So there are no small or unimportant questions today. We're all seeking to clarify and learn. Please go ahead and enter your questions in the chat during the talks. I'd also like to try to make this interactive since it's a relatively small meeting. So I'm going to try to call on you after you enter your question in the chat to actually turn on your mic and have some dialogue. But if you prefer not to be called on, you can always chat me individually, and I'll take that as a signal to just read your question for you. And so with that, it is my distinct pleasure to introduce our first and keynote speaker for the afternoon. Here is Dr. Rebecca Minter, the A.R. Carreri Professor and Chair of the Department of Surgery at the University of Wisconsin-Madison, where she has been since 2018. She received her MD from the University of Texas Southwestern Medical School and subsequently general surgery residency at the University of Florida, which is also very well represented on the call. She spent her early career at the University of Michigan, serving in numerous education-related roles, including clerkship director, associate professor of medical education, associate chair of education, and the fellowship director for the Hepatopancreatobiliary Fellowship. She moved to UT Southwestern in 2017, where she served as the vice chair of clinical operations and finance and chief of the section of hepatopancreatobiliary surgery. It's a good thing I'm not that type of surgeon because I can't even say it. For 2.5 years before being recruited to the University of Wisconsin. Of note, 8 of her past grants have supported education-related research, including a Josiah Macy Jr. Foundation grant to study a new model for clinical education and progressive entrustment of residents in the OR, which is really exactly why we're here today. So she's really led the field in the move toward competency-based education, including numerous publications related to the development, implementation, and use of EPAs. So we are very honored to have you here to share your wisdom with us. And thank you, Dr. Minter.
Thank you, Dr. Smith, for the invitation. It's a very incestuous world in academic surgery because Dr. Smith was the first, as I understand it, graduate of our integrated vascular residency program here at Wisconsin. So it's been really a thrill to watch her career evolve in such rapid ascent. I'm really happy to be here to talk about this. It's my favorite thing to talk about. And I think, are my slides coming through correctly, the right screen and everything?
Yes.
Okay, always good to check. So I think to Murray's point, that was perfect. I think I usually spend most of my time explaining that EPAs are not the Environmental Protection Agency. That is the most common interpretation when you say EPAs. This group is much more enlightened than most folks, but I think that this is definitely still quite new for us. And I hope today I can share with you as much of what an EPA is as what an EPA is not. And as I turn things over to the other esteemed speakers you have here today. I don't have any financial disclosures, unfortunately. I will say I'm not a vascular surgeon, but I am married to one who was doing a ruptured aneurysm all night last night. So I feel like it's a little bit like playing one on TV. I feel like I do know a little bit something about vascular surgery. And Tom Huber trained both of us. So this is a little bit of an imposter syndrome situation. And Give Up Church also trained my husband. So it's, again, something that we are both really passionate about and have talked a lot about EPAs and vascular surgery. And I agree 100% with Tom that in many ways, vascular is set up better than general surgery to use this type of competency-based assessment framework, because what you do is relatively circumscribed, and it will be, I think, be really straightforward to write EPAs for vascular surgery. But before we dive into that, I want to try to just link EPAs into the whole continuum of competency-based training. So I think one of the things that when we talk about a new competency-based assessment framework, people immediately sort of groan and say, gosh, we've spent how many years talking about the competencies and the milestones, and I'm sure many of the people here on this call today had a lot of blood, sweat, and tears invested in developing those competencies and milestones for vascular surgery. And I want to be really clear that this is not at all scrapping that, now let's do the next cool thing in competency-based training. Really, EPAs are the extension of all of the work that you all have been a part of over the last decade, really, and beyond. EPAs really are how do we operationalize our competencies and milestones and really bring them to the bedside with our trainees in a much more effective way than just rewriting our goal and objective and evaluation tools in the language of competencies and milestones. So EPAs are not a replacement for our competencies and milestones. Those things are under the hood, which you'll hear more about from some of our other speakers today. But really, they are the extension and hopefully really going to be the impactful implementation of competency-based education that we've been thinking about and working towards for a very long time. So I think it's really important to just step back and frame the problem that we're trying to solve with EPAs as a new assessment framework and competency-based training. And I think importantly, we have all been really quite dissatisfied with our existing assessment systems. And when I say we, I mean the residents and our fellows as well. So our assessment systems largely have revolved around kind of end of rotation evaluations. We have not done a great job with feedback. There's often a lot of subjectivity, and I think that at the end of the day, it boils down to, you know, all of you, the poor program directors, sitting there at the end of a long period of training and signing off, and there's some people who you're thrilled to sign that, you know, yep, ready to go, and other people who you're like, you really should focus your practice in this very narrow way, but good luck. And so I think that we have struggled to have really transparent assessment systems for progression. It's also a problem for our public, for our patients, and certainly Tom, speaking on behalf of the board, you know, when we sign off on those certificates, we're telling the public that these are well-trained vascular surgeons that are ready. Doesn't mean they can do everything, but it means that they're ready to go into independent practice. And then again, importantly, our trainees have not felt that the current assessment systems provide them with the tools and the feedback they need to progress as rapidly as they could. I think, as I just mentioned, our competency framework has been relatively artificial. We really just rewrote our evaluation tools in the language of the competencies, and we all have seen these. You know, it's like, oh, Dr. Smith, how is she in systems-based practice? I really like Dr. Smith. She's awesome. She's a 6 in systems-based practice. I don't even really know what that means. And so it's just been too artificial, and it hasn't been something that is really very relatable to our faculty who are asked to fill out these evaluations, nor is it relatable to our trainees who get their evaluations in that structure. So well-intentioned, but we missed an execution. I think the milestones have absolutely been better, and I will say I actually think the vascular surgery competencies and milestones are better than the general surgery ones in terms of being more disease and condition focused. But in general, we still have struggled with how do we assess and integrate these things at the point of delivery of care. And I think, again, importantly for our public, how do we have improved transparency for increasing autonomy for our trainees, both for our peace of mind, for the confidence of our trainees, and for our patients who we are asking to allow our trainees to participate in their care. So this concept of EPAs, or entrustable professional activities, really was born out of the Netherlands. Ali Tenkate, who's a close collaborator and colleague from the Netherlands, really coined this term. He's a PhD educator at the University of Utrecht. And he was actually talking with one of his nursing colleagues who told him, you know what, these trainees are so smart, they're smarter than they've ever been. They can pass these checklists at the bedside in terms of putting in a central line, but guess what? Half the time they don't really know what the indications are, what the contraindications are. There's something missing in this current approach that we have. There's some big picture that we're missing in our current assessment activities. And so he really thought about this, and he really thought about this in the context of workplace-based assessment. And what he thought about when he was trying to solve this problem that she brought to him was really, if you think about what we as faculty do with our trainees, is if you were to ask me again, you know, I'm a pancreas surgeon, so, you know, how is a resident, do I trust this resident to evaluate and manage a patient with pancreatic cancer? I can immediately tell you what they can and can't do. It's what I do all day long. I can immediately process that, versus asking me to assess the resident in the buckets of medical knowledge, patient care, technical skill, et cetera. I don't break apart the care of my patient in that. All of those things are under the hood, but I don't evaluate them broken apart like that. So by rolling things up into a discrete element of surgical care that our assessors, our faculty can relate to, and they don't even have to worry about what the competencies are, we're going to get to much better evaluation and much crisper evaluation. And I think importantly, EPAs start with the end in mind. And these are a floor, not a ceiling. And I think that's really important. I'll never forget, I was driving down the road in Dallas and Frank Lewis called me and he's like, Rebecca, this EPA thing, this is never going to work. We're going to need 140 EPAs for general surgery, and that's just not possible. And I was like, a lot of traffic in Dallas. I'm like, well, actually, no, we're only going to need, 25 to 30. And this is a floor, not a ceiling, and it's a lumping, not a splitting exercise, as we'll talk about. So it's really starting with what should every graduating vascular surgery resident be able to do independently. Doesn't mean they might not need help, but what would we say is the floor that a patient should expect, that if you are board certified in vascular surgery, that you have this specific skill set. Many residents will have a lot of skills stacked on top of that. And the idea is if someone's really talented and they are entrustable in that core EPA set, then they can go on and start working on other things. Other people might need more time and need their whole training program just to get to being entrustable in the core set of vascular surgery EPAs. But everybody should be able to hit this floor that we've defined. And as you start thinking about EPAs, that's the body of work you're working on. What is the core of vascular surgery that we would expect all residents to be able to be entrustable to do when they finish? There will be more complex cases that need help. We trust that they'll call for help. And this concept of trust is really an important one. So anchoring things in trust, anchoring these assessments in trust is really different. If you ask me, would I trust this resident to care for my family member with pancreatic cancer? It's a really different construct than giving me a Likert scale and separated out into the competencies, which is totally de-emotionalizes that construct. And as program directors, you know, the greatest compliment you can give when a trainee graduates is, I would trust this trainee to care for myself or my family members. So anchoring the assessments back to a foundation and trust, I think really shifts the way we think about how we give feedback and how we assess our residents in a much crisper and more critical way. And I don't mean critical in a negative way, but really what the residents want, which is give me some specific feedback on how to be better. Really importantly, EPAs define the work of a surgeon. So this is workplace-based assessment. Very explicitly, EPAs have to be directly observed. So this is not the goal of, let's go back to the quote, good old days, which weren't so good if you were a patient, where residents were totally unsupervised. This is meant to be observed assessment. But then it's also teaching all of us how we can be present and observe, but give them more autonomy. But it is workplace-based assessment, and an EPA is meant to define the actual work of a surgeon. So it will mean that we don't write EPAs for things that are really rare, even if they're really important. We're going to have to do that some other way. You know, a surgical airway, for example. We're not going to be able to observe all of our residents doing a crike on our patients to be able to use EPAs for that. That's going to have to be trained and assessed in a totally different way. So I think that this is a really important piece as you think about writing the EPAs, because this is how you get from the 140 that Frank was worried about down to your 25 to constitute the whole core of your profession. This is, however, incredibly hard for surgeons. We actually really like our checklists. We like things to be very crisp and clear, and we like to believe that we have a valid assessment tool. However, we're typically kidding ourselves. If you think about what's currently required with OPRS, for example, we know that you really need about 20 OPRS evaluations for it to become a valid tool. That's because there's a lot of variability in the complexity of the case, and we have Hawk and Dove assessors, and yet we do 6 because that's what was achievable. So we already sort of kid ourselves that all of these different checklists and things are so valid and reliable, but we like them because they feel very objective. EPAs really are the other extreme of that. So EPAs really are about looking at the whole elephant rather than describing a part of the elephant in great detail. But it requires us to embrace subjectivity, which nobody likes to hear that word when we talk about assessment, but I think it's really important that we just say this out loud. We do this all day long. We all assess our residents qualitatively. Maybe qualitatively is a better way to say this rather than subjectively. I think the really important thing to understand is these little micro assessments that we're going to do in workplace-based assessment are low stakes. It's the accumulation of all of that data that becomes the higher stakes entrustment decision. But it does require us to get a little bit more comfortable with things that are a little bit more subjective. I would point out to all of you as program directors, you already know that this is true. You know that really the only valuable feedback on an evaluation tool is the overall assessment. We've done factor analysis to look at that. It's absolutely true. And that's why, again, our current evaluation tools are not very helpful, but it's that overall assessment of how the resident is doing. And that's essentially what these micro assessments do, but with some additional structure that we'll talk about, and really the future speakers will talk in more detail about. So just to kind of summarize all of that, I think that, the promise of EPAs is that this really is grounded in trust. It's going to provide some structure for what that progression should look like for the core of vascular surgery. The goal being that there would be demonstration of entrustment across that core. Ideally, and eventually, we would love for this to be the foundation for serial credentialing within residency, very transparently for our patients, for the nurses, for everybody to know what people can do and how they can progress in a much more transparent way to give our residents more visible autonomy. And I think the really important piece of this from the trainees' perspective is that has gotten harder and harder as our training programs have gotten bigger, is that this really places the resident in the driver's seat with respect to attainment of competence. As you write the behaviors for these EPAs, which you're going to hear a little bit more about in the subsequent talks, we're telling the residents, if you want to be entrustable, this is how you need to show up. This is what you need to look like. These are the behaviors that we expect to see. And if you get entrusted at a lower level, it's not a, oh, I got a 1 on a Likert scale. It's a, I'm putting you in indirect supervision because here are the things I observed. Here are the things you need to do to move up to direct supervision. So if the residents are motivated, which, you know, 98% of our residents are, they're going to read those behaviors. They're going to know how to prepare rather than showing up for the case and having to guess what is it that's important in this case for me to focus on? How do I prepare? They are going to have a blueprint for what progression looks like. Now this requires us to get to some agreement on what progression looks like, and that'll be the hard work that you have ahead of you as you develop your EPAs. But that's the work for vascular surgery to do, to say this is what progression looks like to get to full entrustability for your core diseases and conditions. As important to understand what an EPA is, it's important to understand when an EPA is not. Hopefully you can see the cat in there with the prairie dogs. So immediately when EPAs came on the scene, everybody wanted to, just like we rewrote our goals and objective statements into the language of the competencies, everybody wanted to just rewrite our existing structure into EPAs. So suddenly we had hundreds of EPAs. It's not a narrow slice of surgical care that gets pulled out in isolation. So it's not performing an appendectomy. It's not placing a central line. It's a lumping exercise, not a splitting exercise. So for example, it might be evaluate and manage a patient with right lower quadrant pain, which would include appendectomy as part of the EPA. It might be evaluate and manage a critically ill patient, which would include central line placement. So it is this higher level, again, rolled up, gosh, can this resident do what is necessary to take care of this patient with this problem? It's not all the little subcomponents of that. It doesn't mean that all of the great work that you all have already done in terms of developing simulation and checklists and all of that, those are still important. That's foundational to this. You're still going to do that in the simulation center. But the in the workplace assessment is rolling all of that up because we can't separate that. It's all rolled up in the care of the patient. Really importantly, it doesn't culminate in one big final exam. And I would say this is a different approach that we've taken versus in the United States versus say what has happened in Canada. The reason that we have not focused on some big final exam, which again makes us feel really good, is that if you have 200 micro assessments looking at how residents performed across multiple contexts, multiple conditions with multiple different assessors, and then they come for their big final exam with a hawk assessor and a really difficult patient, and maybe gets to a lower level of entrustability, are you going to throw out those 200 other data points and say, no, this final exam, it's all 100% here? Going back again to that OPRS data, we know that it takes 20 such assessments of the final exam to get to a valid assessment. So really what the approach we've taken is one of low stakes micro assessment, frequent formative assessment, followed by the clinical competency committee, bringing all of that data together in addition with your other data and making that higher stakes assessment decision. So there's no checklist, and really EPAs are assessed iteratively in the workplace. You might have checklists and training in the simulation center, again, that's foundational to your training curriculum, but those are not a part of how we assess EPAs. Again, our goal here is not to say we're not going to have supervision. We want appropriate supervision. We all function in a very high stakes environment with progressive autonomy, with increased expectations from our public, our patients, our regulators. But we create a different safety concern if we don't allow our trainees to have progressive autonomy or progressive entrustment during their training, and we wait for them to have that happen after they have graduated and gone on where they no longer have the safety net of support. So the idea here is that this will actually provide some of that transparency. And I'll tell you, working with some of our risk management attorneys at Michigan, where this work started, they loved this concept. They were like, this is awesome. This is so much better than anything we had today, because then we can say, look, we didn't just turn the residents loose in the dark of night on the patients. They are entrustable based on all of this data. Within our academic medical centers, this provides us with an opportunity to provide that transparency. Tincate has really thought about trust in these 4 conditions, and I like it because it's a really simple construct. I want to share it with you though, because I think it will challenge us to think a little bit, and maybe in vascular surgery this is less of an issue, to be honest. Again, it might be an advantage for vascular surgery with EPAs, but it's a challenge for us in general surgery, where we have gotten bigger and bigger and bigger and have less and less contact continuously with our trainees. If you think about the 4 conditions of trust, ability, what can they do? So what can they do based on when you worked with them the last time? What are their, can they tie knots? Can they do an angiogram? You know, what can they do? That's pretty straightforward. Integrity, do they have favorable intentions? Are they truthful? You know, if they call you in the middle of the night and say they're to tell you about a patient, are they at the bedside? Are they doing what they say they're doing? Reliability and consistency. I think that one's pretty obvious. Are they consistent and predictable in their care of patients? And humility, and this is really a critical piece of entrustment. So do they know their boundaries? Will they call for help? You can have an incredibly talented resident in the operating room, but if they are a cowgirl or cowboy and they won't call for help, or they don't have any sense of their boundaries, they are not entrustable. So they could have hit every other described behavior on how they should do the operation, but if they don't know their boundaries, and they are not yet trustable, and that's a decision that the clinical competency committee has to make when they make that higher level entrustment decision. One of the struggles that we have, again, in general surgery, is that to meet these 4 conditions of trust, you have to know the person and you have to have enough contact with them so that you can progress along these entrustment scales. And so within general surgery, I think we're going to have to think about some residency redesign as it stands to be able to have that happen more quickly. We make these entrustment decisions today all day long, these kind of ad hoc entrustment decisions. These are the decisions you make in the middle of the night when the trainee calls you and tells you about a patient and tells you their plan. You decide, you know, was their plan right the last time? Is what they're saying make sense? Do I trust them? Do I trust them, right? You decide, then you say yes or no, or amend their plan and go back to sleep, or you get out of bed and you drive to the hospital. So these are those ad hoc entrustment decisions that we make all day long, all night long, with our trainees. This is what we are going to assess with the micro assessments. The higher level entrustment decisions, or the summative entrustment decisions, really are where you bring all of that data together, all of those micro assessments, and that's the decision that's made at the clinical competency committee. And so I'll show you how that data comes together to look at that. But the ad hoc entrustment decisions, low stakes, formative, frequent workplace-based assessment, the clinical competency committee is the one that gets to make that higher level entrustment decision about the resident. And that's where that consideration of will they call for help really has to come into bear. And in the Netherlands, where EPAs really form the continuum from undergraduate medical education all the way through to practice, they are fortunate to have a system where these summative entrustment decisions can grant a higher level of independence that's recognized in their country by third parties. We are not talking about that right now in the United States. It's too complicated, we get stuck, but that's the vision for where we would love to head if we have really great engagement and a lot of transparency around what our trainees can do. So Tom covered this well, so I won't really go into this, but and George and others are going to cover this, but we had this pilot with 5 general surgery EPAs. We started with 5. In part because nobody can ever agree what constitutes general surgery. So that was a great place to start with 5 things that no one could disagree with. And the work is underway now to fill that out. But there now is a lot of momentum across all of the boards that are shown here. And I think this is clearly the direction that the American Board of Surgery is headed. Not to micromanage the microassessment side, but really to have that transparency for the public of those summative assessment entrustment decisions, with the idea of getting away from the OPRS and the assessments we do now to one of having the trainees who are applying for board certification be able to demonstrate entrustment of these core EPAs. So I want to just in my last couple of minutes here, and I'm going to keep this short because I saw that Jake had some of this in his slides too. So I'm going to actually just briefly, and I'll cut the videos off, show you what the tools look like that we developed. I think the really important thing is that the micro assessments have to be easy for both the trainee and the faculty member to do. And they have to, I'm just going to start this, then there also has to be the summative assessment support in the terms of the dashboard. So this is the app that we developed that our trainees would initiate this. This is the trainee phone. And so it's typing, and I was the attending. They have to self-assess, and that data has proven to be fascinating, and that'll be the last thing I show you. But they have to self-assess, and then they pick the EPA. It will show them the described behaviors for the phase. They pick the phases of the EPA. So you can see here, it shows them how they're supposed to look if they're at these different levels. And then there's feedback that you can dictate or type, and then they push it to the faculty member. On the faculty side, it really, the faculty member can also initiate that microassessment, but they often, it'll just be pushed to us. You'll get tagged, you're it. So I have it, it comes to me. And then I do the same thing and provide that feedback through the app, and it looks the same here. So I'll skip that. So that's the microassessment mobile application. It takes literally less than a minute to do. I usually do it as I'm leaving the operating room, but it gives us a nice view of how they view their performance and how you view their performance. I'm gonna speed through this because it's a longer video, but I'm happy to share this with Bridget. This is where all the data is brought together. And so this is what Jake will talk to you about because he did such a great job of managing and motivating people. So I'm gonna click ahead here because what I wanna show you is the end where you use this in the Clinical Competency Committee. So all of these micro assessments come together here, and we also get 100% of these have feedback. So you can see the comments here. If we show you one resident, you can filter it down. You can look at just the feedback from the intraoperative piece, all of the comments, as well as this sort of word cloud. This is the most valuable thing to the trainees. So they get a compilation of comments here, and they can start to see the themes of where they need to work. If we look at, come back here. Just don't want to take up all our time here. Great. So if I pause us here, if you look over here, this is one resident, and these are all of her microassessments for gallbladder disease. This is the intraoperative assessment, and this is submitted by the faculty. So you can start to see this shift up towards the left, the far upper right corner towards full entrustment. The Clinical Competency Committee would say, is Dr. Phillip entrustable? Does she know her boundaries? Gosh, it looks like she's headed that direction. And they would make the determination to see she's entrustable with direct supervision, indirect supervision, or to supervise others. And then they would indicate that at the Clinical Competency Committee level. We also had the self-assessment from Dr. Phillip. And what we can see in that, I'll show you in the summary data here. So this then brings everything together for the Clinical Competency Committee. It has all of the data. This is both self-assessment and faculty assessment. We can filter for all those things. We have the comments, and then this is what the Clinical Competency Committee can use to evaluate each resident. And again, I'll share these slides with you all so you can watch the full video and all the functionality, but this allows the Clinical Competency Committee to then make those summative entrustment decisions for each of their residents, for each of the EPAs, see how they compare to their self-assessment. I think, this is really just a shout out to Jake. This does work, and there's lots of opportunity for assessments. These are all the micro assessments in an 18-month period across all of our PGY levels. So these things are directly observable in the workplace. And not surprisingly, the intraoperative phase of care is where we get the most assessments. And I think that's probably fine. But again, because these have to be directly observed, that's a challenge we'll all have to wrestle with EPAs around the preoperative and postoperative phase of care. Not surprisingly, because this is appendicitis, right, lower quadrant pain, this is the place where we do have an opportunity to do both the preoperative, intraoperative, and more postoperative assessment with our trainees because it's happening in the acute setting. You all, again, because you do a lot of emergency surgery, will probably have a lot of opportunities to more than we do for that preoperative phase of care. As I mentioned in our application, we have feedback from virtually 100% of those 1,800 micro-assessments that we have. That has been tremendously valuable, and we have an incredibly smart and talented resident who's been able to use AI and natural language processing to look for themes in that data, which have been fascinating. And this is what is most valuable to our trainees, without question, is that free text feedback. So just to close, I think to show you the value of this, this is some data that came from that same very smart resident, where he looked at the self-assessment data for the EPAs versus the faculty assessment. And this, I think, is a potential opportunity for us in bias mitigation. Because you have those direct observable behaviors, our hope is that that will become more objective than just the subjective evaluation globally at the end. What you'll see here is in the faculty assessment, if we start down here at the bottom, is that gender crosses the line here and does not predict a higher level of entrustment. PGY level nicely predicts a higher level of entrustment, as it should. However, when we look at the resident self-assessment, female gender, or as shown here, male gender, demonstrates a significant increase in self-assessment. And I want to be really clear that our male residents actually still under-assess as compared to faculty. So they are not over-assessing their abilities in any way, but they're more accurate. And the women tend to underestimate their abilities compared to faculty. And what we see here, I think, is just such a beautiful representation of imposter syndrome. Particularly at the transition years, the PGY1 year, we see this significant estimation compared to faculty of the entrustment level and the self-assessment by our female residents. The PGY1 and 2 year, they come together at the PGY3 year, then they pivot back to being chiefs for the first time. In the PGY4 year, they drop again, they come back together in the chief year. And you can see almost perfect overlying of the lines on the faculty side. This PGY2 data was an outlier, and we don't have enough data there yet to know. Obviously, these are small numbers. And I think with larger numbers, these two lines will probably come together at that PGY2 level as well. So we're seeing really nice alignment by gender by our faculty. We are seeing underestimation of ability by the residents themselves and our female residents, particularly at those pivot years of the PGY1 and PGY1, 2, and 4 years. And as they gain confidence, then they come back together. So lastly, I just want to respond to this because this is what everybody says. No one's going to do this. And I hope Jake will convince you otherwise. But I think that for this to go well, we have to consider the evaluation burden in general. And we have to take something away. We can't just add things. We have to take something away. It has to be easy, which we've talked about with the mobile application, and then having the dashboard for the clinical competency committee. It has to be valuable to both residents and faculty. This is really probably the most important thing, because if the residents and the faculty find that this is valuable, if it's useful to know what level your trainee is performing at, if the trainees are getting better feedback, guess what? They're going to engage around doing that. And again, maybe more true for general surgery than vascular surgery, we have to have enough contact with our trainees to be able to implement this. And again, I think this is an advantage that vascular surgery has, where you have a smaller faculty cohort and you work more closely with your trainees. You probably already naturally have greater entrustment happening because you know them much better and you know them early and you know what they can do and what they can't do. Hopefully, though, this gives you an opportunity to give them much more structured feedback as you go. So I will end there without my little Glenn Reguera story and stop sharing to make sure we have time for questions. But I think that this is an exciting time for us. It's been great to see the momentum, and it's fantastic for the American Board of Surgery to be on board with this, because I think that's really the leverage that we need to be able to drive this forward much more quickly than just kind of the organically in a program by program level. So thanks so much. And hopefully that's, Bridget, what you had in mind, and I'm happy to take any questions.
So Dr. Mentor, thank you so much for sharing your wealth of information with us. Truly enjoyed your talk. I have a question, then I have a series of questions from our audience. So I have two questions for you. Number one, do you envision a future based on EPAs where some residents could graduate sooner than 5 years of vascular surgery, and some people may take longer? That's one. Second question for you is, over the course of years, the evaluation for surgical residents has been focused on objectivity, based on case numbers or coming to milestones, or any sort of thing. So I think, does it sound like we're going back to the era of subjectivity, and the fact that the millennials or newer generation, they already are very focused on objective evaluations, on objectivity? Is this the right generation to offer this new tool to? Thank you.
Okay, so going back to your first question, remind me, was related to the
Time limit, sooner or later. Yeah.
Yes, so that, we would love to get there, but we get stuck really quickly when we start there because of the Medicare funding for training and just the workforce realities of trying to staff your services and so forth and so on. And so what how we've tried to think about this is that we would love to have a more finished product, right, when we get done with training. So if somebody meets those, is entrustable in the core vascular surgery EPAs during their training, then ideally, let's say they're going to, they want to focus more on endovascular skills, then great, let them focus more on their endovascular skills. Or they want to focus more on, whatever it might be, aortic stuff or dialysis access with Tom Huber, or whatever that might be. So you'd have kind of these core EPAs, and then once they're entrustable, they hopefully can then continue to have some autonomy within the context of your training program. There is currently a trial going on called Promotion in Place, being led out Deb Weinstein at Harvard, across all disciplines. And we've talked a lot about this, about what are the opportunities. If the board decided in the future that residents, once they're entrustable in all the core EPAs, and let's say they've passed to their written exam, they're board eligible, then they could be credentialed in your institution, because they then would be board eligible, but they'd still have another year to finish. Then you could put them into a more independent mode within the construct of training. Again, these are, I think, much further down the road sorts of things for us to think about, but this provides at least a construct upon which those things might be possible, because now we would have the data to say, this person's ready, this person's not. So that is the future idea. The objectivity piece, I think, is a great one that we hear all the time. And I think we kid ourselves right now that we have these highly objective tools. We don't at all. And we are subjective already, right? Like every evaluation you fill out at the end of a rotation is a subjective evaluation. And it's much more subjective because you don't have any anchors to say, here's what I'm seeing, here's what I'm not seeing. So I think the idea with the EPAs is that we're going to describe a set of behaviors, you see them or you don't. I think that's why we see better alignment between our male and female residents, is that the behaviors are the behaviors, and the feedback, it anchors you when you give your feedback on those behaviors. And so it is actually more objective than it may seem. We also are highly subjective right now in our clinical competency committees. I mean, I remember when I sat on the clinical competency committee when I was at Michigan, it would get to that wellness one and be like, well, so-and-so's been working out a lot. They must have great wellness. Give them they're fully whatever in the milestones. So, I mean, we're highly subjective already. So I think this actually gives us some data as a foundation. But at the end of the day, you know who's good and you know who's not good. I mean, that is the bottom line. And so it's actually trying to provide some foundation to aid that opinion or to counter that opinion, and hopefully a more transparent way than what we have today. I actually think the millennials are the perfect generation for this. They want a lot of feedback. And they think the feedback we give them sucks, as they will tell you. And so the idea here is that you're giving them feedback based on those behaviors. It gives you the language to give them feedback, and it's specific versus good job, great hands, And so I actually think they really embrace this. And the fact that they can be the driver of it by initiating the evaluation, it gives them an easy way to seek that feedback, but it gives them a structure, it gives us a structured way to give them that feedback. So I actually think they're the right generation.
That's good. Thank you. So we have a few questions from the audience as well. I know that my friend Dr. Bichara had some questions. Carlos, you want to speak up?
Oh, yeah, sure. Can you guys hear me or no? No? Oh, okay. Thank you. Thanks. Great talk. So my first question was, I mean, it's interesting that the self-reporting that you said the female residents, I don't know if it's a confidence issue or they're just more humble or so, I mean, but let's say it's a confidence issue. Do you feel like you can use this? I know that we talked in the past about sending some residents to, you know, kind of to boost their confidence, but whether it's like, you know, some courses that help them with public speaking and stuff like that. So I wonder if you encountered that or when using those EPAs.
So this is data that we just produced. I was actually one of our medical students and Chris Dahl, one of our general surgery residents. What I think is fascinating about the data, and I think it tells me, is that we need to think differently perhaps about how we give feedback and how we support our female residents, particularly when they're in these pivotal times, and really boost them up and encourage them. And when they under-assess themselves, we need to say back to them, nope, you're up here because you did these things. What I think is great is that they're coming together, you know, once they gain confidence, they're coming right back together with their male colleagues in terms of their self-assessment. So to me, it really is a reflection of confidence. And I think it tells us this idea of, you know, treat everybody the same maybe is not actually right. And maybe we need to think about how we give feedback and how we support and encourage our female trainees perhaps differently, particularly at those junior years or when they're taking on a new responsibility. And it's not meant to be gender biased. It's just an important fact of the way that women have been enculturated in our society. And so I think the data gives us an opportunity to think about how do we build that into resident and faculty development as we roll out these types of assessment framework. It also allows us, I think, the other, you know, what we thought we might see with the self-assessment data, which we haven't for males or females, is that if you also, it helps you in that, do they know their boundaries piece? Because if you have a resident that over-assesses their abilities consistently, then they're not entrustable, right? Like that's the person who thinks they are better than they are. And so you need them to come back down to the faculty line before you would give them a high level of entrustment.
And one more question, Dr. Mehta. You mentioned the millennials like feedback, but also they hate negative feedback. You could give them 10 great things and one negative remark, and they focus on a negative remark. Sorry if there anyone on the, but has this created any friction, like their self-assessment in relation to the faculty assessment?
I would say, Carlos, as a department chair, that I don't think that's unique to millennials. I can say my faculty at all generations, if I gave them 10 positive comments and one negative one, would come back and focus on the negative ones. So again, I actually think that the millennials are a little better at receiving that. So I think that I think they get a bad rap, but it's a balance, right? Like I don't actually think that they receive that constructive feedback any worse. The nice thing about the EPAs is that, again, if you do the faculty development right and faculty give the feedback according to the behaviors, if you look at what's happened in pediatrics, it's actually led to some really positive discussions where, in fact, some of the trainees have come back and been like, you know what, you said I was feeling trustful, but when I look at these behaviors, I actually didn't do that. I did this other thing over here. So the idea is by having those behaviors, it strips some of the emotion out of it. And you're like, look, I saw you do this. I didn't see you do that. Here are the descriptions for this level of entrustment. If you want to get to the next one, you got to do this. And so I think it helps by not having it be solely subjective and anchoring to those behaviors. It strips some of that emotion out of it.
Sounds good. Thank you. I know that Dr. Shames has written some questions as well. Marie, I know you're having fun at the chat section about the simple app versus other. Do you wanna ask a question so we can ask Dr. Minter about the part evaluation of the app system?
Sure. So thank you, Dr. Minter. So we just recently, maybe at the beginning of the year, introduced Simple, and we're struggling with adoption. So, I think that while I think the platform is similar, you pick an operation and, how much supervision did they require, which is kind of what we're talking about, right? Do they need to be supervised, or can they do this on their own? And while it doesn't get into all the details of all the components of what an EPA would be, I think it's in that direction. Tips and tricks on how to get people engaged. We've made it resident dependent, and then I'll just bug them when I don't get them and send them a whole bunch of requests for them to complete their simple side. But it's also a similar, my understanding is, they assess themselves, we assess them, our program director gets the feedback. I really liked the development of the review process that you guys have come up with, and so how do you put all of that together? Because I think that getting them to do it, is it useful, and then what to do with the data.
So I have lots of thoughts about that. So I think Jake should certainly chime in after I do. So we also had Simple and we had poor adoption, and I think that it's a great tool in concept, but it gets back to nothing's going to get adopted if doesn't have perceived value, in particular by the residents, right? And so I think one of the key differences is that, again, the idea here is that the residents want feedback, they want better feedback. So in our app, for example, you have to give feedback. You cannot get out of the assessment without giving the feedback. In Simple, that's not true. So they don't really necessarily care what dots you give them. They really want to know feedback on how they can do better the next time. So they really cue into the feedback. So that's one piece. So they don't find the value in the same way in at least our residents in the Simple app, nor did our faculty, because they didn't see how it was impacting our trainees in terms of becoming better the next time they did that same case with them. So I think that's one key difference. The other key difference, again, to the objectivity question is that there's a lot more subjectivity in that, because you don't have those behavioral anchors. So Simple is set up to do the EPAs, but you have to click on a little button that says I to see the descriptive behaviors, and nobody does that. So again, it becomes kind of a Likert scale, and there's a lot of kind of likability that rolls into that, and how much did this resident annoy me, and how much do I like them, and there's a whole lot under the hood there related to, which we've done a lot of research on, how aligned you are in terms of your personality focus. And so again, I think the nice thing with the EPAs is having those behavioral anchors that hopefully helps bring us back to the same place in terms of how we're thinking about how they did. You can strip away some of those more subjective emotional things. Jake, why don't you comment, because you lived through, Simple was here before I came here, so.
Yeah, I mean, I agree with everything that Rebecca said. I think when we rolled out Simple at the University of Wisconsin, it was met with like a little bit of excitement early on, but then it fairly quickly dwindled. And I think the reasons that you highlighted were true. I also think it's hard for people when you sort of get Simple updates on a monthly basis in terms of how well your program is performing. And that was not as visible to other members of the department. So the faculty couldn't see that. The residents couldn't see who was engaged and who wasn't, because the data was all housed within the Simple people. And I think that people took more to the EPAs because it was much more discrete and limited. There were 5 of them. They knew which cases they could submit EPAs for, and they would get an answer back from those people, which is, again, I think one of the benefits that your group has, having a smaller scope of practice. The other thing that I think, I don't know if you mentioned that this was specific to your trainees. I think one of the difficulties that you may have is that when we did Simple and when we did the EPAs, it was really variable, right? There were some residents that were gung-ho about this and were great, and there were others that didn't do a single one in 2 years. And we had 54 residents in the program at UW. If you have 5, it's going to be a different percentage of how many people will adopt and will not adopt. So I think those will be some of the challenges, and I'll certainly touch on those too. But I do think that there was more perceived value with the EPAs than there was with just straightforward case evaluations via simple.
So along the same line, I have another question, because most of the general surgery programs have bigger faculty numbers, and most of the vascular surgery programs have, between 4 to 8 faculty members. So one of the things I can easily foresee is that the data gets diluted out, and perhaps a true picture emerges if there's more data points, i.e. more faculty members. In your trial sites, did you notice a difference between large size sample faculty member programs versus small size faculty programs?
I'm going to defer to George on. I'll say one thing I think, Faisal, that's challenging is that I think we're the only program that had the dashboard. So I think in the pilot, so that has been an important piece of our assessment tools. It's not just having the mobile application, but what do you do with that data? So every part of the pilot was everybody did that a little bit differently. But George, I don't know if you.
Sure. No, so it turned out to be very variable, and I'll show some data from the pilot, and you'll see. So we had 28 sites in the pilot, and the University of Wisconsin did the best, and they've heard that from me before, but they did a really great job. Some other places did a really great job. We had 2 sites that actually never did an EPA evaluation in 2 years, and most of the larger programs actually picked a small number of faculty champions who owned individual EPAs, because as Dr. Shame said, so we've had simple for a long time, and I'm pretty sure that in 2021, 3 or 4 years after we adopted it, I'm the only person who regularly does simple evaluations. And I honestly do it because of the opportunity to dictate comments at the end of the case. So I tell people stuff and then I dictate it, because the end of the case is the worst time in the world to give somebody feedback because they're distracted. And that way they can reflect on it later. But I think a small faculty is great. The thing that kills workplace-based assessment is when you create one as a resident, you don't get a faculty response because you don't know if they respond. And after a while, you just get tired of doing the work. And so having a small faculty means it'll be actually very easy for the division chief to say, look, you're the only one of our faculty members who hasn't done any evaluations, and you need to get on it. Because that's harder when you have 50 faculty members, because you can sort of hide. And it's not so easy to hide when you have a small number of people.
And I would say, interestingly, in our data, about 50% of, it was both. We have some faculty who are really great, because I just want to get it done. So I just do it myself when I get OR. I don't wait for the resident to ping me, because then I'll be on to something else. But then we have others who only do it if the resident pings them. So we have both. We have a bunch where we have only the faculty did it and then not matched to the resident, and we have the ones where the resident did it. So I think it's a credit to Jake and really his leadership in terms of the rollout as the program director and engaging folks around this. And he'll talk. I purposely didn't talk about that because I know he was going to. I think Dr. Conway's question is a really, really important one in the chat. So did you find EPAs helped underperforming residents? So I don't think we're far enough along in our experience with this, but I will share with you what they found in some more mature programs in internal medicine or pediatrics, because I think that we are going to find the same thing. And that is that attrition did not change. So they still had, roughly 25, interestingly, it's not so different than surgery, 20 to 25% attrition. But what was really key was that they found them earlier. So they found them all after the first year in medicine rather than at the end of the second year. And so that was because it became visible much more quickly, because they had the EPA data and those outlier trainees were visible, because we all know, and looking at resident evaluations, the poor program director is stuck with everyone saying, this resident is terrible, I wouldn't let them operate on my dog. And you're like, all the evaluations look great, thanks guys, what can you do? And so the idea here is these microassessments, again, because they're not part of this high stakes end of rotation evaluation, when you bring all that microassessment data back together in the dashboard, you quickly start to see that resident who's falling behind. And then the idea would ideally be to be able to intervene early before they get labeled, before they get further along in their training program and can't be remediated. That's the idea. So I don't think we have been at this long enough to be able to really answer that question, but other specialties who have implemented EPAs and are farther along have absolutely found that that's the case.
Sounds good. Thank you so much, Dr. Mentor. Truly appreciate your answers. So we'll move on to the next speaker. It's my honor and privilege to introduce Dr. George Cirosi to you. Dr. George Cirosi is a Robert Hux Professor of Surgery and Vice Chair of Education at University of Florida. He is also serving as a Program Director for General Surgery there for over a decade. He obtained his medical degree from Harvard Medical School and completed his General Surgery residency at University of Michigan. He's a renowned surgical educationalist and has served as a chair of the EPSITE exam committee. He has been oral board examiner for the American Board of Surgery for over a decade and also serves now as a director for ABS. In fact, he is the lead director for EPA development in general surgery. He's an expert in competence-based surgical education. We're really honored to have him here with us today. And we're looking forward to him sharing his experiences and learning from his mistakes and pitfalls that he learned in the general surgery EPA. Dr. Cirosi.
Thank you. I'm going to share my screen. You'll have to let me know if if you're seeing it. So, good. Yeah. Look, are you guys seeing my slides okay?
Yes.
Good. Perfect. So I know I was tasked with talking about tips and pitfalls, but I actually just thought I would tell you a little bit about the EPA journey in general surgery, and I'll highlight what I think are successes and pitfalls. I would say that we've actually been pretty fortunate in the EPA process in general surgery because we haven't had any like epic disasters. It's actually gone surprisingly well. I'm sure that the disasters are yet to come, but we have learned, I think, a lot of lessons along the way. And so I will hopefully highlight those. So I just wanted to talk briefly about the ABS's pathway and the move to competency-based education. This began kind of about 6 years ago. Steve Evans and David Mavi were the chairs of the American Board of Surgery before the board's reorganization, and they committed to working on this together, Mary Klingensmith as well. And we started actually by learning from the experts, and you'll hear from some of the experts later, which are our colleagues in Canada who are way ahead of us on this, and also by folks in the Netherlands. And so for the first couple of years, we just learned a lot about what was going on in competency-based education. By 2017, we'd realized that EPAs were probably the way to go for competency-based education, and we began developing the process. And Dr. Mentor actually may correct me because she was actually there at the very beginning, and so I may misdescribe it, but there were some groups of experts together, and eventually we came up with 5 EPAs because, as she said, it was very difficult to come to any kind of consensus about what the EPAs in general surgery are. And then we ran a pilot study, which was done for a couple of years in 2018 to 2020. It was obviously a little bit COVID affected, and I'll share with some of the pilot data at the end here. And right now we're working on developing a set of EPAs, a complete set of EPAs for general surgery, because one of the lessons we learned is that actually is important, that a partial set is problematic. So I would say probably the first lesson I would share for you is if you're going to develop the EPAs, try and develop all the ones you plan to have, because only having a small set kind of creates challenges, which we'll talk about. So I think one of the things that was really important about this is that the ABS, I think, was successful at this because we got all the involved parties together, and the ABS functioned as a convener in this process. And so the Association of Program Directors in Surgery are going to be the effector arm of any EPA pilot, right? The program directors are going to have to implement it, and they need a seat at the table. And I think it's particularly laudable that the Association of Program Directors in Vascular Surgery are driving this, because I think that you will own it whether you think you'll own it or not. And so we also involved fellows and residents, which I thought was really important. And then EPAs and milestones are linked. And the ACGME believes in milestones, is not going to make milestones go away no matter how much we try. And so we have to learn to collaborate with the milestones with EPAs. Both, I think, general surgery and vascular surgery are fortunate that our milestones are very gestalty and not very specific. And because of that, it really creates a space for EPAs. Because EPAs are tied to individual patient behaviors and individual disease states, and our milestones are not, it's actually relatively easy to implement EPAs in light with our milestones. If you look at the orthopedics milestones, for instance, they actually look a lot like EPAs, just not, in my view, really greatly done ones, but in the United States, I can't speak, the Canadians have actually done a much better job. And so having all those groups at the table is, I think, really important. So as I said, we look to our neighbors, and we'll hear some about the Canadian experience in vascular surgery. But Competence by Design, which is being done by the Royal College of Physicians and Surgeons in Canada, is going to convert every training program in Canada to an EPA-based training program. I think the final date is by 2024. So likely before we implement general surgery EPAs, every training program in Canada will be EPA-based. They've had a long experience with it, starting in orthopedics and some other specialties. And I think they learned that it obviously allows demonstrated competence before progression, and that time ceases to be the measure of education, but rather a resource for your development. And they've found them to be very learner-centered. The Netherlands, which I understand less about, but I think in many ways may even more evolved, have really implemented EPA in the transition to practice. In many of the centers in the Netherlands, as a general surgery resident, if 3 independent faculty members give you a summative entrustment that says you're practice ready, as a senior trainee in the Netherlands, you're allowed to book cases under your own name. You're not an independent practitioner, but you can actually start cases as an attending. So they've really, I think, done the promotion in place in a way that we would love to have done. And then obviously pediatrics was the first US specialty to publish a full suite of EPAs. And we were fortunate to learn from Bob Englander, who was involved in that and really played a key role in the medical school EPAs as well. We initially developed a suite of almost 40 EPAs as our first attempt, and it was very hard to get any kind of consensus, and the thought of doing a pilot on 40 EPAs seemed daunting. And so because of the variability with program sites and the difference between a large university training program and a 2-person-a-year community-based residency, it was very important we pick key things. And so 5 EPAs, the most common conditions managed by general surgery residents, were sort of where we started. We started with a subset. We looked at a variety of things, and I think as you think about your EPAs, I think this is important. The EPAs will have to be done at every program in the United States if they're a requirement by the Vascular Surgery Board. And so you have to make sure that there are things that everybody does. You can't have them be things that only the busiest high-end places do. I think the second thing is they really, one of the things about competency-based education is you're really educating towards the desired outcome, which is what do people in practice do? So I think you need to think very thoughtfully about what are commonly performed procedures. And so as we thought about our 5 EPAs for the pilot, we asked the question, what are the most commonly done things in general surgery? And you'll see. And then I think the thing that we decided early, and I believe in fairly strongly, is being a surgeon is more about doing operations. And so assessing people in the preoperative phase, can they pick the right patients to do the operations on? And understanding that people can manage the complications of the procedures that they do. I think those things are critical for entrustment as an independent practitioner, and to only focus in the operating room is a mistake. I think that we used reactor panels, so we would have a group develop EPAs and another group react to them who didn't have any role in the development. And that level of independence and objectivity was very helpful to our process. So as you think about that, you'll see that it's built into our process. And then I think that as we got started in this, we really focused on the feasibility of EPAs in residency training. We were told by Bob that some of our EPAs would fail. We were fortunate that none of our first 5 did. I imagine when we develop the full set, some of them will. And so you have to be prepared for that possibility, and this will likely be an iterative process. So the 5 EPAs that we settled on for our pilot were to evaluate and manage a patient with an inguinal hernia, evaluate and manage a patient with right lower quadrant pain and manage appendicitis, to evaluate and manage a patient with gallbladder disease, and these include both pre-op, intraoperative, and post-operative phases, evaluate a patient and provide initial management of a patient presenting with blunt or penetrating trauma, sort of the trauma bay and disposition phase of trauma, because that's obviously one of the key functions of surgeons. This was originally written as a 3-phase EPA, but might actually collapse into less of that because the pre-hospital phase has turned out to be pretty hard to evaluate. And then the last, which is actually a single-phase EPA, which is to provide general surgery consultation to other healthcare providers. This is a little bit more of a broad EPA. This one only has a single phase, and I'll talk a little bit more about what that means as we get into the development. So I wanted to actually just spend some time telling you how we wrote them, because I do think that that's helpful, kind of as a step-by-step guide, and I'll highlight what I think were some of the tips and pitfalls that we encountered as we did it. So as we alluded to, we sort of got started on this in about 2017. And so this began as a one-day face-to-face meeting at the ABS offices. We had 13 people. We had 3 experts / facilitators. So Karen Brazel, who was actually the director who really started who was really responsible initially for the EPA process, and is a longstanding program director at the University of Oregon and an expert surgical educator. Bob Englander, who helped us from pediatrics with his expertise. And then Rebecca, who actually is very modest, but also participated in the writing of the medical school EPAs and has a lot of experience in EPA development. We had 10 writers, and that was because we were going to write 5 EPAs. We had 5 teams of 2 who were going to go about writing the EPAs. We got about an hour of orientation, a very high-level talk, and then we got to work. And we had some reading provided to us before, but I would say a little bit of this was a learning by doing process. And I think that that's probably okay with this because it is an iterative process and you will get better and better at it as you iterate through it. So the work of a writing dyad actually really started by describing the activity. What's a brief description of the activity? Thinking about what are the essential functions of this professional activity. And as you think about those essential functions, really thinking about what are the essential functions that create entrustment. At the end of the day, remember that residents are acting potentially independently in your name, right? So that creates a level of entrustment. It's not that you trust them to do this in their own name, you're trusting them to do this in your name, which I think really raises the stakes of entrustment. And if you think about that, I think that's very important. We asked the question, are there phases of care? And we decided early that there would be a preoperative, intraoperative, and postoperative phase of care. The intraoperative phase is the easiest assessed and the most assessed. And I think that probably reflects our current training environment. We tend not to actually watch residents all the time. Mostly we watch them in the operating room. And EPAs are evidence-based, but they are not a curriculum. They are really descriptions of activities and the essential functions of an activity and the pieces of that activity that are necessary to create entrustment for independent practice. So as an example, these are the descriptions of 2 EPAs. They can be quite discrete, like gallbladder disease. So gallbladder disease is a condition commonly encountered by general surgeons, both in the elective and emergent care setting. The essential function of this activity is the definitive treatment of the spectrum of benign biliary disease, as well as the recognition of diseases requiring specialty referral, which is a big part of that entrustment in both adolescents and adults. Whereas a general surgery consult EPA is a much more broad EPA. So all general surgeons must be able to serve as consultants in the inpatient, outpatient, emergency, and operative settings. As consultants, they play a unique role in interacting with clinicians and other disciplines to provide optimal patient care. So what you can see with this particular EPA is a lot of this is actually not about specific knowledge, rather, but about the behaviors that involve functioning in a system. And so that's an EPA that assesses some of the other core domains of competence like systems-based practice, professionalism, and interpersonal communications. So for the gallbladder disease EPA, and this was the one I wrote, which is why I picked it, we decided that the essential functions in managing a patient with gallbladder disease are to synthesize information necessary to make a diagnosis, to perform a cost-effective workup, to communicate the diagnosis and treatment options both to the patient and to other healthcare providers, including the risks, benefits, and informed consent, and I think most importantly, to recognize high risk and contraindicated patients. To be able to perform the procedures that are required to treat a patient with gallbladder disease, to be able to provide routine postoperative care, and then to recognize complications of the treatment and potentially manage them, but for certain to recognize them. We had to decide what diagnoses were included in the gallbladder EPA. So we decided to include biliary dyskinesia, acute cholecystitis, chronic cholecystitis, gangrenous cholecystitis, acalculous cholecystitis, gallstone pancreatitis, choledochal lithiasis, and polyps. But we explicitly made the decision to exclude gallbladder and biliary cancer because that's really not a core general surgery thing. That's really a surgical oncology or hepatobiliary pancreatic surgeon function. And so because it's not necessary for core general surgery, it probably is outside of the EPA. We felt that operative injuries to the biliary tree are typically managed by specialists and not by core general surgeons, although they sometimes are. And choledochal cysts were again thought to be outside of what we were interested in assessing. We created this document, and I recognize that this is probably hard to read, but it basically contains all of the elements with a little more detail about the individual functions. And I think one of the things that was really important is actually, defining what things are included and excluded in the EPA. So an EPA document has a description of the activity, a list and an expansion on the essential functions, at least in our conception. and then a description of the scope of the EPA, which are included or excluded patients, references that were related to sort of critical references that were used in the development were included. So the critical view of safety is obviously an important concept in safely performing a cholecystectomy. And so we reference that in this article, and understanding indications for cholangiogram is also important. So those references were included. Once we'd done that, these were shared with a reactor panel. And basically what we heard from the reactor panel at our initial episode, we focused probably too much on the preoperative and the postoperative phases of care and not quite as much on the intraoperative phases. And so we went back and actually defined some very key essential components of intraoperative entrustment that were called out in the EPA. And I do think these are surgical EPAs, and I think that was an early mistake. And so I would share that with you. With each EPA that involves operative procedures, identifying what are key elements that people have to demonstrate to achieve entrustment in the operating room, I think are very important. And we then revised the EPA descriptions. We then proceeded in this, we did this in the setting of Milestones 1 rather than Milestones 2.0. And I would say that Milestones 1.0, at least in general surgery, were a little more conducive to EPA development than I think that Milestones 2.0 are. And that's a personal opinion, and I'm happy to have people disagree with me. So we had a second face-to-face meeting. Each EPA was mapped by the whole group to between 3 and 5 EPAs, which were essential. And we did this because EPAs and milestones belong together. In many ways, I think of EPAs as the filter that allows a practicing surgeon to understand the milestones, which really are the milestones, the domains of competency and the competencies. I call them milestones. In fact, they're really supposed to be sub-competencies in correct terminology, but you know, patient care 1, for instance, is actually a sub-competency and not a milestone. The individual points are the milestones, but the EPAs are a filter to the milestones in my view. And they make them make sense to clinical surgeons. Because I think honestly, when you read the milestones, they really only make sense to professional educators. And we're counting on clinical surgeons to help us evaluate our residents. The working group as a whole mapped them, and as you can see, I did EPA 3, and so we picked patient care 1, which was making a diagnosis and managing conditions, patient care 2, which in the old parlance was managing complications, patient care 3, which was performing operations, medical knowledge 2, which was the knowledge of surgical procedures, and interpersonal communication 3, which was actually communicating in the operating room as the key milestones for the gallbladder EPA. And then in order to actually write the EPA, and this I think did work better with the first round of milestones, has proven to be a little harder with the second round of milestones. And Bernessa may comment on this because she has actually been leading the work group that's been revising our first EPAs to be more compliant with milestones 2.0. What we did is we actually then looked at we demonstrated this mapping. And so what I told you is, and you've seen these diagrams, but this is specifically for gallbladder. So managing a patient with a gallbladder disease focuses on 3 domains of competence: patient care, medical knowledge, and communication. It focuses on 5 specific competencies, and then they receive rankings in those levels. And as you populate the milestone with the EPA with various levels of supervision, implicit in that is progression along the milestones. And I think that as you talk about eliminating work, I would encourage you to try to do this because programs will still have to complete milestones.
Okay, she didn't say, hey, my ABI's decreased.
No.
So that's normally something that,
So in order to actually write the
unless the patient said I had a test.
the EPAs, we then looked at the milestone documents, and each writing dyad selected key elements
You're not using the things
from the milestones and mapped them to the subcompetencies to create the language for the EPAs. So what does this actually look like? So what we did is, this is an example of 2 of the general surgery milestones 1.0 represented as a table. And so what you can see is I've highlighted certain words as you think about it. So at the basic level, which is the resident can only observe the activity or can't do it, the resident lacks basic surgical skills, they're unable to reliably perform basic procedures, they do not have basic knowledge. Whereas if you look at the 4th box over, which is someone who's practice ready, the resident demonstrates proficiency in the handling of most instruments and exhibits efficiency of motion during procedures. They move through the steps of most operations without much coaching and is making intraoperative decisions. They can perform many of the core operations. They have significant knowledge of operative steps. And so we took these points on the milestone grid, and then what we did is we converted it into statements, which are the functional activities at each level. So a resident in the intraoperative phase of a gallbladder who can't do it, who is at the very lowest level and can really only watch it. So in the operating room, these residents are not able to describe the boundaries of the hepatocystic triangle. They lack spatial awareness when they move instruments, laparoscopic instruments. They overreach with an instrument. They can cause injury to the liver removing it. They have critical efficiencies and may apply cautery well in advance. Their movements are rough, lack smoothness, and often demonstrate discoordination between their two hands. So, you know, this is a little bit harder because I'm speaking to vascular surgeons, but when you talk to a bunch of general surgeons, they're like, I know that resident, right? And it's beginning to develop a description, whereas someone who's able to operate with direct supervision can describe the anatomic boundaries of the hepatocystic triangle. They understand the relationship between the gallbladder and the common bile duct. They understand the principles of the critical view of safety, but because they're still requiring direct supervision, they cannot generate it reliably independently. Their instrument handling is safe, but often tentative. They sometimes can't use both hands in a coordinated method. They're able to do parts of a cholecystectomy with only minimal assistance, but probably not the whole operation. And so you can sort of see implicit in there the progression. And those stages came from our looking at the stages in the milestone document. So one of the pieces of advice that we received from Bob Englander was that people really like stories. And I'm not going to read these because these are long. And so they encourage us to write vignettes of what people look like at each level. I would say that in the process of doing this, we heard that surgeons don't like stories quite as much as pediatricians. And it's a lot of work to write these vignettes, and almost nobody looked at them. Surgeons are very much about outcomes. And so when you describe the functions, surgeons will look from function to function level and do it. They don't really need kind of a nice story. And so I would encourage you maybe not to write the vignettes, because I think we spent a bunch of time doing it, and I don't think anybody used them. So I think that would be probably one of our pitfalls and one of the lessons. And you can see, and I'll just sort of flick back and forth between these two slides, you can see how these behaviors describe progression across the levels. And I'm happy to share these slides with you so that if people want to look at them more clearly, or I can supply the documents if you really want to see what the individual levels look like. So having written these 5 EPAs, we decided it was time to give them a trial. And so we ran this pilot study. And this, you've seen some of this data before from Dr. Huber. It was a 2-year longitudinal multi-center pragmatic trial of EPA-based assessments, really looking at implementing EPAs and providing microassessments to clinical competency committees and asking them to use them. And we really were mostly hoping to figure out if you could actually do EPAs feasibly in diverse training programs. We were hopeful to begin to define how many microassessments you need to begin to achieve assessment. I'm not sure we did that, honestly, but we did at least assess the feasibility. And so we used those 5 EPAs. There were 28 volunteer sites. 24 of them were medical school-based programs, and 4 of them were independent non-medical school-based programs. We required program directors had been there for at least 3 years, so they were secure and comfortable in their job. They were programs with educational infrastructure, and they were committed to uploading their data. We made the decision because we didn't want to get a lot of variable data, that each program would be assigned only 2 EPAs to report data on. I would tell you, as you think about EPA implementation, we heard from our pilot sites that that was probably a mistake. If you only do a couple of EPAs, residents don't continually get assessed. They jump from a service where they do them to where they don't, and it really hurts you in the habit of frequent formative assessment. And so again, I would say that doing only a part of it was probably an incorrect decision that we didn't recognize initially. This is a list of the sites, and you can see many of them are institutions that you may work at or be familiar with. We did collect, as I said, 4 sites that were not medical school based, because in general surgery, about half of the training programs in the United States are not at medical schools. I'm going to share sort of some of the data at kind of a high level, just to give you a sense of what we were able to do over 2 years. And really, we did this over a year and a half, because the last phase, the last half year of the study started in January of 2020. And so it was pretty COVID affected. And we didn't really collect data, but from a handful of sites. So over the course of this study, residents received microassessments in regular care. They were reviewed by their CCCs. And then summative entrustment decisions were reported. So the ABS didn't actually collect the microassessments. Those were housed in the individual programs. And we only collected the CCC summative assessments of residents. There were a total of 1,100 residents who were involved in toto in the trial, but obviously some residents came in the second year and some residents left. So on typically we studied about 800 and some residents. And I'll show you on the next slide. We collected at all of those 28 programs about 6,200 observations, although I would say that's actually probably an understatement because we actually only have complete data reported for 2 periods and maybe 2.5 periods, because we have not gotten data, I think, from everybody in the 3rd and 4th periods. On average, residents, even with just 2 EPAs, got about 6 observations. Interestingly, residents who actually had summative entrustments made, on average, had about 7 observations, and actually they probably had a lot more than that, because I think the challenge in doing a study in the middle of training is it's very hard to say that you don't trust a 4th-year resident to do an appendectomy when you've had 3 years of experience with them, even if you don't have a lot of data. And I think that that is one of the challenges. And I think, as you implement this, you probably just have to pick a group and go with it, and maybe not necessarily implement it for everyone else. Because I do think that we tend to entrust by history right now, and maybe not by performance. Most of these observations were done by surgical faculty. So this just shows you that in the first 2 periods, we had about 840 residents. And after the initial lead-in period, even with just 2 EPAs implemented, we were actually collecting observations on about 40% of the residents in the training programs. And some programs opted to implement all 5 EPAs, but we only collected data on 2. It does mean with only 2 at any one time, about 60% of your residents didn't get any microassessments, any observations in that 6-month period. This trial ended up being about a 10% sample of US general surgery programs, because we had about 800 residents and there are about 8,000 surgery residents in general surgery in the United States. So it's actually, although it was only 28 programs, it's actually a pretty nice sample. So this just shows you that not all programs are created equal. I'm pretty sure that that line that keeps getting better and better is the University of Wisconsin. And this is the number of observations that they collected in each period. You can see some programs started out well, maybe lost steam. Some programs never really launched. Some programs kind of puttered along. Some programs got a couple of periods. They looked like they were on a great trajectory, and then we just lost their data. And one program had one really good period, and then we never heard from them again. So I do think that as you implement these, and I think Jake's talk is really valuable, this is hard work implementing them, and that's what we learned from this trial. This just shows you by cumulative observations by program. You can see that, some programs collected 1,200 EPA assessments on their residents in a relatively short period of time. And that is realistically, if you had 20 EPAs, each with 3 phases, and you need, say, 20 to 30 microassessments across each EPA, you're talking about 1,200 observations in a general surgery resident, right, per resident, if you're going to collect that kind of data. So this does require a lot of data. As you can see, a couple of programs never got launched. The University of Florida, I think, is one of these programs here in the sort of steady but not very respectable, and we did not do a great job of implementing it in my own program. Not surprisingly, the majority of the observations, and this is the observations collected over all residents, so it's important you recognize that 60% of the residents that go into the denominator here didn't have any observations. We collected a lot more observations in the operating room than we did pre or post-op. And this is just the number of people that we received summative entrustments on. And so what you can see is that we received summative entrustments across all of the EPAs. We got more summative entrustments about people in the operating phase, which just reflected the amount of viewing that they saw. But we were able to actually collect a respectable number of both pre and post operative phases. And so I do think that that is important, and you collect useful information there. I think one of the things that's interesting, and these are very crude pieces of data, you can see that preoperative and postoperative entrustment happens pretty early. Level 3 is indirect supervision, and you can see that many people are at that stage. You can see that intraoperative entrustment builds longer. This line at the bottom is actually the gallbladder EPA, and only at the 4th year were people actually beginning to be, on average, entrusted to perform those independently, and only for sure at the chief level. Other operations like inguinal hernia and appendectomy achieved entrustment a little bit sooner, summative entrustment. And so I think that actually is a little bit of what I would consider to be kind of face validity. I think that's what I would expect. Learning to do gallbladders reliably is hard because some gallbladders are easy and some are brutal. And appendectomies and inguinal hernias are more consistent and a little easier to do, more mid-level operations where people are independent. So just as some lessons learned, and then I was just going to tell you about where we're headed next. So we concluded that this is feasible. We also concluded that having a full set is preferable to having a limited set, because once you want to get people in the habit of frequent formative feedback, you don't want them to have to pop in and pop out of that. You want to be doing this all the time. And if only certain things that you do are assessed, it becomes problematic. Implementing this change is going to be really hard. The most important thing is teaching faculty and residents how to do it. And I think it's important you think about developing your EPAs. It's even more important you think about training your training programs, how to implement them. And I'll defer to Jake because he's going to talk a bit about that. I think one of the things we learned is a lot of care that's provided right now is actually not directly observed by faculty, and likely to really assess some of the things like preoperative and postoperative behavior, we are probably going to have to change the way we train. We learned that smartphones are critical. You really can't do this without a smartphone. Pretty much everybody used a smartphone. Every physician has one. It's with them all the time, and interfacing with that smartphone is going to be key to collecting data. So where we're going right now is trying to define the full set. And so we're in the middle of doing this with the Scope Council. And the Scope Council, and I think the composition is important. So it's a very broad group of all the stakeholders, right? Because we really want input from all the stakeholders. So we have 3 members from the General Surgery Board. We have a member from each of the ABS component boards. There are 5 ABS component boards so that they can comment on both what aspects of their specialty they think belong in general surgery, and so that they understand what we're going to assess in general surgery as they begin to write their own EPAs. We had 3 members from the APDVS because, as I said at the beginning, the program directors are going to be key to this. If the program directors do not buy into this, this is dead in the water because they will be the implementers. We had a member from the Fellowship Council, which has actually already developed EPAs for some of the non-ACGME accredited fellowships and is pretty far along, so their expertise was valuable. We have a member from the RRC because the RRC is a part of this, although they're not directly involved. And then the American Board of Colorectal Surgery is the only other surgical board that requires general surgery certification for their own certification, and we thought it would be very important they would be involved. There is obviously some turf between colorectal surgery and general surgery, and so we thought it would be really important to negotiate that at the very beginning. So this is our timeline. We had our first meeting in February. We hope to be done with our suite of EPAs by 2022. And then hopefully we will have final EPAs written about a year later so that programs can begin to play with them before they're required to implement them. That's the plan. I think this is ambitious, but we will try and meet it. We developed some principles for writing EPAs, which I'll share with you. And I think these are important. So it's important to remember that the unit of assessment of EPAs is actually individual residents. And so EPAs are about individual practitioners. The EPAs and the ACGME milestones are complementary rather than exclusive. EPAs are bundles of multiple competencies, right? They're not individual competencies. And all of the ACGME domains probably need to be assessed by the full set of EPAs, because otherwise it's going to be really hard to complete them both. And if people have to do both bits of work, it's going to be hard. The purpose of general surgery EPAs, and I think this is really important, is a clinical competency assessment of core elements of general surgery. It is not going to assess all elements of general surgery. It's really like the NISQIP of general surgery, right? You're going to take a small sample, hopefully a large enough sample, to verify that a resident is clinically competent, but you're not going to be able to assess everything. And you have to, I think, be comfortable with that, because otherwise you'll end up with way too many EPAs and it'll be unmanageable. Entrustment is built by frequent formative workplace-based assessment. The things that are embedded in EPAs have to be performed often enough that you can get frequent workplace-based assessment. And then we thought that the whole set of EPAs should reflect our definition of general surgery, which is fairly broad. Every training program has to be able to do it. And then I think these last 2 things are important. One of the things that Joe Beiske has said over and over and over again, if we're going to implement a new assessment, we have to replace it. We have to replace something, because constantly adding is problematic. And so as you think about your EPAs, think about other requirements that you already have that you might be able to eliminate in an EPA framework that will create alignment and buy-in. And then I have just 2 more slides and then or 3 more slides and I'll stop. There are a few implications of these principles. The first is that it's competency sampling or a biopsy. It is not competency of every aspect of general surgery, right? And then I think that I've already actually highlighted these, so I'm going to keep going. General surgery program directors would be delighted to know that we might be able to get rid of FLS and FES if we get all of the EPAs. That's a challenge. And this is just to give you an idea of what actually general surgeons do. And I think thinking about your case data is important. I've taken some liberties to lump it together. There are actually 127 distinct cases that are considered core and score, but actually only 18 cases with some lumping are performed 10 or more times. The data that we have on operative assessment suggests that 10 is an absolute minimum to get an estimate, but if you just pick those 18 case categories, that actually encompasses about 2/3 of what the average general surgery resident does. And these categories that residents do frequently actually overlap very nicely with what diplomates do. I might just let Jake talk about the implementation challenges, but because I think that that's a better focus for him, and then I'll stop and I'm happy to take questions.
Fantastic. Thank you so much, Dr. Cirosi. That was a great talk, and you didn't have the pleasure to see it, but there's some incredible discussion going on in the chat, and I'm going to try to distill that and share it with everyone. I actually think, Dr. Shames Murray, your last question was something maybe you could say out loud for the group about the monthly assessments.
Well, it looks like Jake responded. So, I think as we look to, your comment on we have to remove something, we can't just keep adding, I think as faculty and the residents and everybody just gets burdened with paperwork and, surveys, et cetera, we're all looking for less things to do, not more things to do. So how do we use this to, and Jake responded that, unfortunately, end of rotation evaluation is an ACGME requirement. So we kind of have to still have an end of rotation evaluation, but the content of that could certainly be changed, right? If you've addressed your milestone competence and your skills and other things that the EPA does, could then it could be a very simple, kind of 5-question evaluation of, do they meet criteria to go on to the next rotation? I don't even know what that means. That's the end of ours. Do they meet the, I don't know what the next rotation is. I have no idea if you should be on the next rotation.
I've heard some pretty thoughtful people advocate that if you get a good sample of your EPAs, you probably can assess, the medical knowledge, the patient care, and maybe a lot of the communication elements with EPA-based assessment. And it may be that your end of rotation evaluation really focuses in much more on things like professionalism, patient ownership, leadership, accountability, which are actually probably better things to assess in an end of rotation evaluation than medical knowledge. My favorite saying about end of rotation evaluations is all they really tell you is the last bad thing that trainee did on your rotation, because that's the only thing you end up remembering at the end of a rotation. It's sort of the last thing that sticks out, and they're really not a very effective format. I would point out that unlike our colleagues in Canada who have the incredible fortune of having all of medical education under one roof, in the United States, yeah, I'm super envious. In the United States, the ABS certifies individual surgeons, the ACGME/RRC certifies training programs, and those things diverge. The ABS is really focused on clinical, EPAs in our view is a clinical competency assessment at the time of certification. Because right now we just ask program directors to say, hey, they're ready to practice. And we don't really give them any yardstick to measure that. And I know those of you all of you are program directors, right? You sign off on people. And at least in general surgery, if I sign off on 6 people, every other year I got 1, I'm thinking to myself, I hope this is gonna be okay. And I think that by creating a common definition of what's okay clinically at the end of training, this will be amazing for the public. And that's why we think this is so important.
And I see Dr. Minter's comment too about this, and I was gonna ask, I didn't remember if the ACGME was in any way, shape, or form involved in the effort to build out EPAs, but they're obviously aware of it. And I wonder if that's something we could be forward thinking about in vascular surgery to engage them so that like RRC requirements sort of align with what is evolving in our own training programs?
So as we did this at two levels. So we have an EPA advisory council, which is a bunch of fairly senior educators who are really tasked with making sure that we don't wander off into the wilderness. And on the ABS EPA Advisory Council, we've asked Eric Hombo, who is the person at the ACGME in charge and tasked with milestone development, to be a member. And so Eric is constantly reminding us of the importance of the milestones and the link between the ACGME Outcomes Project and EPAs. And then in our writing group, we have a member of the surgery RRC engaged, and I would encourage you to do that as well with the vascular RRC, because I think they need to be aware of the process. Now, we were super fortunate because Karen Brazel, after she rotated off of the American Board of Surgery, joined the RRC. And Karen is our rep from the RRC. So it really allowed us to get an expert in the room. I am delighted to have her because her feedback is critical.
And then earlier in the chat, Dr. Malger, you had a comment about implementation and sort of the reality of autonomy with entrustment. Do you want to comment or ask your question? I'm not sure if others can hear him, but I don't think I can hear you. Is your mic on? You're unmuted. I can go back and find your comment too to read it for you. Okay, I still wasn't able to hear Dr. Malger. I found the comment though. So his comment here was that the EPA discussion has been great. It reminds me of how autonomy is dealt with back home in Brazil, where he did 2-year vascular surgery fellowship. And he comments that one of the core differences is the barriers encountered by trainees to actually exercise that autonomy that is granted by an EPA when they reach a certain level of entrustment between the trainees and the patients. And what they're allowed to do is hospital administration. And I think this has come up a little bit in the medical legal discussion I've seen kind of in the chat, but I don't know if Dr. Cirosi or any of the other panelists have comments about actually executing on that, summative entrustment that you are ready to do this.
So I do think it's the promise of EPAs, but we may not be ready for that right away. So I think there are two things to remember. Your statement of entrustment is the level of supervision you would grant them for the next similar case. So it's actually not the level of autonomy that you gave them for the case you evaluated, but based on the observed behaviors, it's the level of autonomy you would give them if they did that same case 10 minutes later. And so it may lead to greater autonomy, but it doesn't absolutely have to. Now, I do think that with promotion in place, I think that it is possible that if we reach a stage where you can potentially complete your EPAs early and you could pass your qualifying exam, that would make you board eligible. And then you could be functionally credentialed as an attending, even though you were still employed as a resident. And I think one of the things that Joe Beiske has said, which I think was really mind-blowing to me, but very powerful, is when you're taken into a training program, you get two things. One is a commitment for training, and the second is an employment contract. And so you could actually complete the commitment for training, but still have to honor the employment contract. And I think as you sort of separate those two, I think that creates some of the opportunities for the generation of autonomy. Most people are incredibly busy. And if you could have another faculty member in your division, kind of at less cost, that would be amazing, right? Think of what that would free you up to do. And so I think that is the promise of promotion in place. The governing board of the American Board of Surgery has two really important people on it. The first is Mark Chasson, who's the CEO of JACO. And we are hopeful that as this matures, that we can leverage some of Mark's contacts to maybe allow JACO to write some language in about promotion in place. That would be amazing. And then Karen Fisher is also on our board, and she is an incredibly experienced healthcare lawyer who participated in the writing of the ACA and has deep contacts in the Healthcare Finance Administration. And we're hopeful that there might even be in the future the ability, if we can pull this off, to allow people potentially even to submit bills, right? That's a pie in the sky dream, but.
So with the few minutes we have left before the next speaker, I want to ask about the other end when someone isn't promoted in place, but actually it's going to take longer to reach that minimum bar in training, and who pays for that GME position when it's beyond the circumscribed 5 years. Any thoughts on what that looks like?
I'll defer to others, but I would just say that at my home institution, I think something like 30 or 40% of our positions are actually not paid for by Medicare. And I think with some clever line transmission, I suspect your institution would hardly notice an extended period, right? And I do think we have a commitment. At UF, actually, if we extend someone and remediate them, actually as a department, we're obligated to pay for it. I think it's rare. The data from the Toronto orthopedic experiment showed that something like 1/6 or less of people required more than the standard amount of time, and only about 1/6 of people could actually get done faster. And so I think the vast majority of people will probably train on time.
Yeah, I would say, Bridget, I think that, this happens today, right? We have residents who need an extra year. And we pay for them, and it's the right thing to do. I think going back to Dr. Conway's question earlier, I think the idea here would be hopefully we identify those struggling residents earlier with EPAs so that we can actually help them earlier. Usually these are quite delayed recognition of problems, and kind of after the 3rd year and you're like, wow, this person's not ready. And so if we can move that upstream, then I think we'll actually perhaps have fewer residents who need that extra time, but that already happens today.
In the same context, I have a question. I'm sorry, I know we're running behind time, but I think certain traits can be learned. We can learn how to tie. We can learn how to sew. There's certain traits like integrity, which wins the trust of other persons around it. How do you? I think by the time people start the residency, training, either they have it or they don't have it. How do you expect spending more time will teach somebody the value of integrity or reliability, or winning trust of others?
I'll respond to that. The American College of Surgeons is actually putting together, or has started, we've met once, a committee on resident selection. And I think it probably will come into some of that assessment, rather than the typical, letters of recommendation and your ABSITE and your USMLE score. We may have to start thinking of other tools to look at, emotional intelligence and self-awareness and those. And we don't have a solution because, frankly, I don't know that the system's broken. We select residents, most of them finish, and most of them do a good job when they're done. The system isn't broken, but we certainly could do it better.
I think one thought I would share with you is, some of what we've learned from the whole disruptive physician process. And I think one of the things about EPAs that can actually be helpful with that is embedded in the descriptions are the behaviors you need to demonstrate to be at that independent level. And I think that many people who struggle are completely unable to self-assess. And I think your ability to continually show them where they fall down, you may not change them, but you might improve their socialization, right? I frequently contend that I'm not a very nice person, but I'm well socialized. And I do think that that's not super uncommon in high stakes professionals. And I think that it may be that we can't make them better, but we can make them more socialized. So.
All right, thank you for those answers and comments. We're going to move along to our next speaker. And I also just want to remind our remaining speakers that there are people that are filtering in and out throughout the afternoon here. So if you do have a little bit of redundant content, please don't worry about that at all. We appreciate it. So the final talk before we take a little break is from Dr. Brunessa Lindeman. She's an assistant professor of surgery and medical education at the University of Alabama in Birmingham, where she also serves as the fellowship director for endocrine surgery and was recently also named as the section chief for endocrine surgery. She's the associate designated institutional official of the clinical learning environment and previously served as an associate program director for general surgery. She completed her MD at Vanderbilt, general surgery at Hopkins, and endocrine fellowship at the Brigham, where she was also an education research fellow and has a master's in education and health professions. Her education-related accolades are probably too numerous to count and include awards for both her teaching as well as her education research. And her experience with EPAs is extensive, as with all of our speakers today. She was a member of the AAMC drafting panel for core EPAs for medical students and also for general surgery in 2017. And now she's chairing the drafting panel for endocrine surgery EPAs and recently received a research grant for a national pilot study in their specialty. So I think her experience in a small fellowship in endocrine, a subspecialty, is what made me interested in having her share her expertise with us as well today. So Dr. Lindeman, you have the floor, and thank you for being with us.
Oh, thank you so much, Bridget. I had asked her to shorten that. But anyway, it is such an incredible privilege to be with you today. And I took Dr. Smith's words to heart, that I left in some of the things that I tend to say. And some of the things that, as I was presenting EPAs as a new concept to my colleagues in endocrine surgery, some of that background material that I'll review just briefly, because I think everybody's getting a crash course in EPAs today, or you may already be familiar. But I think sometimes, at least for me, hearing things in a slightly different framing can be helpful. And I think we're going to move from this big, broad view about what are EPAs and how are we doing this in a very large specialty to a much smaller scale view. And hopefully there may be some lessons that you find may be very applicable to vascular surgery as well. So I'll talk a little bit about the background work that we did, how we went to identify the list of EPAs as we were able to define the entire set of EPAs for endocrine surgery, and then the process that we used to draft them, which you will note really was mostly a carbon copy of the process for general surgery with a pandemic twist thrown in. Many of you may be familiar with the work of John Cotter and change management and the need to create this burning platform. And so some of that, Dr. Mentor framed for us, but that really there is concern about the outcomes of our current training system. And so our model is one of fixed time, but what we know is that not all trainees progress in this very linear fashion. People may progress, in their own time. And so if we say that they only have a certain number of years for training, some people may not make it all the way to the end, to the outcome that we want. And so our goal system would be one where we define and then fix the outcome. And then it doesn't matter how long it takes someone, we let people take as long as they need to get to the outcome. We were talking about some of that with promotion in place and serial credentialing, things like that. I used to have the words variable time on that slide, but I think we kind of discussed how the logistics of training may not always facilitate that. And then the other thing that I challenge colleagues to think about is, how do you, if we are measuring progress based on numbers, how do you know? How do you know when someone's done enough cases, or have they done index cases? Do they have to do the hardest cases? How do we define those things? This interesting study from the gastroenterology literature, I think defines learning curves really nicely in colonoscopy. And that just because you've done a case doesn't mean that you've demonstrated competence for a case. So in this graph, at this 150 colonoscopy mark, you can see that there's a very wide spread of skill level, the metric being success rate within 20 minutes. And that if you put everyone, through 300, you double that experience, then everyone is much better. But if you look at the top performer, this person didn't really gain that much more proficiency over that time, where they could have potentially been focusing their efforts on something else. I'm not sure if you're familiar with these data. It's from General Surgery. It was published in Annals. It's from Brian George, who developed the Simple app that we've been discussing a little bit. And data from Simple, thousands of data points, looked back at what people could do in their last year of training, what ratings that they got, and the red or pink shaded bars are those that were competent for practice, and the blue were ones that still had concern. You can see that everybody could do an appendectomy. The vast majority could do a gallbladder or a hernia repair, but by the time you got to doing colectomies or certainly non-core procedures, this last bar on the graph, then there were more concerns about trainees being ready for unsupervised practice. And so EPAs, by contrast, would ask us to take a more holistic view, and one that, as Rebecca described, that most of us think about anyway, right? Would you trust this person to do whatever it is that you're getting ready to do with you not being there? Do you feel comfortable being a phone call away? Do you want to be there at the elbow? And we make these what are truthfully ad hoc entrustment decisions on a day-to-day basis. You know, I operated with a resident for the first time today. And so, you know, we spent some time kind of reviewing background and negotiating how much of the operation she was going to have autonomy to do. And so to provide a brief history of the evolution of competency-based medical education, we've talked about, you know, we started with competencies, that was back in 1999. And then along came the milestone project in the 2010 sort of era, and surgery milestones in 2012. And then EPAs were sort of defined back in 2005. Rebecca and I both had the privilege of serving on the AAMC group that wrote the EPAs for entering residency in 2014, then pediatrics, and then general surgeries we've been talking about. And I think maybe I have it on the next slide, but we were fortunate to start this process a little bit later in fellowships. And I know that Rebecca's been very involved in the Fellowship Council and working on their EPAs as well. The definition I usually use is that EPAs are an essential task of a discipline that an individual can be trusted to perform independently in a given context. And so we want to start with the end in mind. What really do we expect people to be able to do at the end? And so I threw in some examples for medical students and the EPAs for general surgery. But really, as we start to think about, you know, fellowships like the Fellowship Council or for endocrine surgery, then thinking that our focus was more on how do we get more specific into what our subspecialists do. The other framing, I think this is actually from Jim Collins, is good to great. But one strategy in leadership is ensuring that you have the right people on the bus. And I think, you know, George showed that the ABS worked as a convener for the general surgery milestones. But I think having all of these constituent stakeholder organizations expressed interest in competency-based education and in EPAs was certainly something that, for my specialty of endocrine surgery, added legitimacy and showed that there was a lot of momentum moving in this direction to say that this is something that we wanted to be an early adopter for. And so I applaud you for taking moves in this direction already. I think one of the things we haven't discussed yet today that was really important in my specialty was to think about the difference between curriculum and assessment. Endocrine surgery had just been going through a curriculum revision. Now, we are not an ACGME accredited specialty, and so it has really been our specialty society that writes a curriculum, and there are no endocrine surgery specific milestones. So we had to spend a lot of time unpacking really what's the difference between curriculum, which I would define as, you know, the core conceptual knowledge and strategic processes that learners engage in order to develop competency, right? And assessment, which is where you determine whether the core conceptual knowledge and strategic processes that you want someone to develop have been learned. You want to know, can the learners then demonstrate that they have achieved competency in whatever the core knowledge and processes are? And so I describe this or summarize it maybe a little bit more simply as saying that curriculum raises the ceiling of what we expect learners to know and do, but assessment is really the floor of what they have to demonstrate that they do. And so we would return to this frequently as we were writing EPAs, that the EPAs are really the floor, and we know that they have to be directly observed. So while we might want to write something about the most complex condition that we might see, chances are not every trainee is going to be able to demonstrate that in a repeated way such that they could demonstrate that they are entrustable to perform that without supervision. So we're thinking about the floor of what they have to be able to do to be a safe practicing, in our purposes today, vascular surgeon. And so then we move forward to try to identify what are the EPAs going to look like for endocrine surgery. And so our group charge, you see our 4 little nice organs there at the top. What are the essential tasks of our discipline? And as others have pointed out, that question is a little bit harder than one might think. And I saw some discussion in the chat, people talking about what potential EPAs might be. And so I sort of put together like a straw man for what I thought might be a good idea, things that I thought, based on my own experiences in EPAs that we might go with. And you may see some similarities with what we ended up with, but I'll kind of walk through a little bit about how and why this list changed. And I think that process was very important for us, and hopefully there are some lessons that you can take away as well. But really focused on, sort of run-of-the-mill thyroid nodule and classic garden variety thyroid cancer, then more advanced thyroid malignancies, benign thyroid disease like hyperthyroidism, hyperparathyroidism, and then adrenal masses, both those found incidentally and those found to be malignant. And so after sort of throwing out that list and engaged with a reactor panel, which were members of our executive council, I think there were some concerns about, how this was developed and what might we be missing. And so then we sort of scaled back and began to think about, what are our fellows required to do? So the AAES, the American Association of Endocrine Surgeons, our specialty society, has additionally a fellowship accreditation committee. And that group is charged with defining the requirements for our fellowships for the programs, but also for graduates. And so I've pulled out the requirements to graduate from an AAES accredited endocrine surgery fellowship. And so the first requirement is to complete cases in defined categories. This is not foreign to anyone. I think all of our specialties have this. And so, there are specific categories, 10 adrenal operations, 10 central neck dissections, 5 lateral neck dissections, and 10 advanced operations. And the advanced cases are listed there below that. So it's reoperative surgery in a variety of locations, an adrenalectomy with a multivisceral organ resection, a cortical sparing adrenalectomy. You can read them for yourself. But the language actually was very helpful for us in going through this process of EPAs, because the categories that were chosen, this is actually verbatim in our fellowship requirements document, says that the reoperative and advanced designated cases are intended to demonstrate exposure and experience with the breadth of complex surgery and exposure to multidisciplinary care required, particularly for revision operations. And so you'll see that some of these themes begin to show up in our EPAs. Requirement number 2 is ultrasound examinations. And so there are certain numbers that people have to do for a total of at least 15 ultrasound related exams. Additionally, you have to have case discussions at multidisciplinary conference, 12 cases in total, and that we have a national video conference held twice during the year. And so that could also be included. And then our fellows are required to have a scholarly experience. And there are a wide variety of potential categories defining scholarship very broadly, but they have to do at least something. And so with that in mind, we started to reformulate our EPAs, but in the same way that George showed how the numbers that residents complete and how they align to what diplomates in practice actually do, we took a look at something very similar for endocrine surgery. And so you can see, there's a wide range in terms of these cases, but most everybody has a very robust experience in thyroid surgery. The numbers get smaller when you look at the medians for especially lateral neck dissections or reoperative neck dissections. There's a robust experience in parathyroid surgery, less as you get to reoperative cases. And then there's a pretty good volume of adrenal surgery, with 13 laparoscopic adrenalectomies being the median number, but sensitive to the fact that some of these, the minimum for some of these is very small. If we move to other sections, particularly some of the advanced categories, we actually break our neuroendocrine tumor experience down to operative experience. And so there were 15 programs that reported operative experience. The median number of cases was 4. And then there were some programs that had a clinic or tumor board experience only. And that's all that is required is the fellows have to have at least some experience with a neuroendocrine patient. It does not have to be an operative experience. But even despite that, there were 7 programs that did not meet that requirement. And so this was going to be problematic as we thought about, what our EPAs were going to be. Additionally, there are some endocrine surgeons whose spectrum of practice includes pediatric endocrine surgery. That's certainly our case here at UAB, but that is not the case everywhere across the country. And so you can see the last column, the number of programs. There are, 6 programs where the fellow reported doing a lymphatic dissection in a pediatric patient. And so that's another area where there's a lot of variability. And pretty much everyone was meeting the ultrasound requirement. And then scholarships, similarly, everyone was meeting that requirement as well. So how did that inform the list of EPAs that we came up with? Well, it turns out that because poorly differentiated or very aggressive, like anaplastic thyroid carcinoma, is not a common disease condition. Malignant adrenal masses are not common disease conditions. And then I demonstrated from the numbers that are from our fellow case logs that neuroendocrine tumors and pediatric endocrine surgery are also not very common. And so we wanted to identify a mechanism for where we can account for the variability in our training programs. Right? So I can tell you that if you are the endocrine surgery fellow at MD Anderson, you're going to be seeing a lot of advanced thyroid cancer and a lot of adrenal malignancy because that is what they focus on. Whereas in other programs, you may see none of those cases. And so this paper is actually an AMI. It's the Association of Medical Educators in Europe, but they publish these guides to medical education. I would highly encourage you to look them up. They provide great information. But Ole Tenkate, whose name has been invoked many times today, sort of the father of EPAs from the Netherlands, he's the first author on this guide. And really within it, one of the things that they make space for is this recognition that there's variability within training programs. And so while you can have a floor that you define that everyone that's pursuing the specialty needs to demonstrate entrustment in, that specific programs may have expertise that they can provide to their trainees, that those trainees at that program may be able to demonstrate entrustment for an additional set of EPAs. And so those are termed core EPAs and elective EPAs. And so this framework is what we decided to utilize in endocrine surgery, that we have 10 core EPAs that must be mastered at a specific level by all endocrine surgery, AAES endocrine surgery fellows. And they're really, for core EPAs, you should not be able to graduate from the program if you don't demonstrate the required level of entrustment for all of them. By contrast, we also defined 4 elective EPAs. And so these pertain to a focus area of interest within our discipline, but not all trainees in the program or all trainees across the country are required to demonstrate any degree of mastery in these in order to graduate. And this would allow for some flexibility in our training. So let me go through what these ended up being. And I put on this slide what the EPA is, plus the number of cases that our fellows have in that area, the median number of cases. And then the last column is the number of programs that had fellow data about this. So the first 6, George talked about the general surgery EPAs. 4 of the 5 were evaluated across 3 phases of care. So those are the more clinical ones that relate to a specific disease process. And so we have 6 disease process specific core EPAs in endocrine surgery. And then the single phase of care in general surgery, that's the consult EPA. For endocrine surgery, these are not disease process specific, but they're a little bit broader and may be assessed in a variety of ways, or across a variety of conditions, I should say. So the 6 3-phase EPAs are evaluate and manage a patient on initial presentation for a thyroid nodule or differentiated cancer. You see there's lots of experience in that. Evaluate and manage a patient with benign thyroid disease. Similarly, lots of experience in that. We actually, our numbers don't differentiate by diagnosis. And so as George was talking, that we may not get the EPAs right at the outset. This may be one that we decide to combine at some point in the future. If we feel that, parsing out different conditions within thyroid disease is problematic. And that'll be a question that we answer during the pilot. We also have persistent or recurrent differentiated thyroid carcinoma. It's a common problem. You see there's a lot of experience, but it is quite different than the management of an initial presentation. And then there's initial presentation or persistent or recurrent hyperparathyroidism. And again, there's a lot of experience with that. And then there's evaluation and management of a patient on initial presentation for an incidental or functional adrenal mass. And that was also very common. In the single phase of care, we focused on evaluation and management of a patient with an inherited endocrinopathy, as that's a very common condition. Utilizing ultrasound in the care of an endocrine surgical patient, one of the direct fellowship requirements. Contributing as a member of a multidisciplinary endocrine surgical team. As you may recall, that's a requirement that people have to present at least once at a multidisciplinary conference. And they also have to participate in scholarly efforts related to the science of endocrine surgery. And there are many possibilities for how to fulfill that criterion, but that also was included as part of our EPAs. Our 4 elective EPAs, I sort of alluded to this on the slide with the arrows, that we have advanced thyroid malignancy, and so we included medullary thyroid cancer, poorly differentiated cancer, and anaplastic. None of those are very common, and there are only certain centers where the fellow will gain enough experience to be able to be directly observed and be found to be entrustable. Similarly, adrenal malignancy or metastasis falls in that bucket. Patients with neuroendocrine tumors, and I didn't have enough, I probably could have taken another line, but this includes gastrointestinal and pancreatic neuroendocrine tumors, GEP-NETs. And then finally, pediatric patients with endocrine surgical disease is a standalone EPA. You can see that the numbers are pretty low, but there are some centers in which there will be fellows that will be able to be entrusted for pediatric endocrine surgical disease. Okay, the last section that I will go over is our drafting process. You'll note as I previewed that this will be very similar to the general surgery process, with the exception that ours occurred entirely by Zoom during the pandemic. So we started this process in about April of 2020, so shortly after everything shut down for most people, and have just recently wrapped that up in the spring of 2021. So it took us a little over a year. And I have these other 11 phenomenal people to thank. So you may note that we have 14 EPAs that have been drafted. There were 12 people in total. And so everybody did lots of work, but they were very, very engaged, and it made it actually quite an enjoyable effort. So the scope of our work, after we identified the target EPAs, then we drafted them. Similarly, we divided into pairs or dyads. Everyone wrote the description and the essential functions. And then we mapped our EPAs back to the general surgery milestones for lack of endocrine surgery specific milestones. and because the general surgery ones are written in a slightly more generic way that would continue to facilitate our use of them in endocrine surgery. And so after that milestone mapping, we wrote the expected behaviors. I'm sorry, I did not change the slide. We did not write vignettes. We took a cue from the general surgery pilot, and that no one really utilized the vignettes. And so we saved a lot of effort in skipping that. This is the worksheet that we used. I think George may have shown it as well. But if I'm drafting, you know, the multidisciplinary endocrine surgical team EPA, then we put the title at the top, and then the next description is, you know, why, just a little 2 or 3 sentences about why that EPA is important as part of that specialty. And then a list of the functions of the learner. So I'll show some examples. This is actually the general surgery consult one. And so you see it's 2 sentences about why that should be included as an EPA. Here are the functions: elicit the major question, recognize the level of urgency, review and synthesize essential information from lots of different sources. I'm not going to read the whole thing. This is the gallbladder one, which George also showed. It's quite a bit more, because whereas consult is a single phase, gallbladder is a 3-phase of care. And so here is the preoperative functions, here's the intraoperative functions, and then the postoperative functions. And then there are inclusions and exclusions that he discussed. And so, as I mentioned, we divided into dyads. So I had this little chart of, you know, who was working on what at any given time. But the one that I'm showing you is evaluation and management of a patient with persistent or recurrent hyperparathyroidism. This is actually one of the first ones that we ended up doing, and it turned out very nicely. So you can see the description of the activity. Endocrine surgeons consulted to evaluate and manage patients with persistent and recurrent hyperpara after previous surgery. The increased complexity of the reoperative setting requires additional considerations compared to the initial setting. So that's why this is a standalone EPA as compared to just hyperparathyroidism generally. And then I've truncated the functions, but similarly divided into 3 phases: preoperative phase, gathering and interpreting important clinical information, and there's a list of where that may be included from. Perform a workup to confirm the presence of one of the 3 types of hyperparathyroidism, consideration of other etiologies, determine the optimal preoperative localization studies, so on and so forth. The intraoperative phase, synthesizing an operative plan, you know, accounting for the prior incision, the fact that you're going to have scar tissue, the suspected location of where the parathyroid abnormality is based on your imaging. Perform the operation with delicacy and economy of motion, very important to an endocrine surgeon. Manage the scar tissue, manage any operative complications or unexpected findings. Again, there's more here. I just truncated it for purposes of speaking about it. And then the postoperative phase of care, initiate and oversee that, including disposition, timing of discharge, final pathology. And we had to be very careful about our wording because some surgeons always keep patients overnight. Some surgeons always do these on an outpatient basis. So allowing some flexibility in practice was very important for our group. So once we have all of those functions listed out, the next step was mapping to the milestones. And so we tried not to map, we tried in ours not to map to more than 6. This one's mapped to 7 initially written out here, but I think we truncated it. And I think I said this maybe in our practice yesterday, but you know, we did everything by Zoom, and I thought that by and large that went very, very well. The one thing that if I could have met in person, I would have done the milestone mapping in person. Having done it both ways, right? I did it in person with medical students, did it in person with general surgery, and then had to adapt to try to do this remotely through COVID. Created a similar Q sort using a Qualtrics form and asked people to rank. So of all of the milestones written there to the left for general surgery, there are now 18 with milestones 2.0. asking people really to pick the two that are most essential to the performance of this EPA and then sort of rank the others in decreasing order of importance was a really challenging task for people that had not done this before and were less familiar with the milestones, because as you can recognize, there are some endocrine surgeons who are very involved in education, but there are others that are not. And so we had to sort of help people that were not familiar with milestones come up to speed on what all of this meant, in addition to what EPAs meant. And so there's what the Qualtrics form ended up looking like. I'm happy to talk offline with people if they're interested more in that. But as George was discussing, you know, the goal was to try to get good representation of all of the general surgery milestones or subcompetencies with the entire set of EPAs. And the only one that was left out was professionalism 4, which is attending to your own well-being. And it's not that that wasn't important, it just did not rise to the level of top 6 most essential EPAs for any of those that we have. And here are the elective ones which got mapped as well. Then the last thing that we did was writing the behaviors that can be observed. So for that same EPA, I'll just pull out a couple of things. So this person that has, you know, limited participation, we decided that we don't actually let anyone, we don't force anyone to just stand there and only observe. We usually let them do something. So we renamed the scale to be limited participation. That's coming to the, since I'm leading this committee to revise the existing EPAs and decide on the scale, this is going to be the scale for the general surgery EPAs too. But limited participation, so they can describe the steps, but they can't really coordinate their hands to accomplish dissection of normal planes. They can identify normal things. By the time you get to indirect supervision, you can maybe talk about the impact of scarring and the imaging findings on your approach. You can dissect the normal planes and some reoperative planes, but you can't really manage anything that's difficult. And the practice ready, which is really the graduation standard, you can customize the operative plan based on all the factors that we discussed. You can dissect nearly all reoperative planes. You can adapt your plan based on what you find. You can manage complications that occur, so on and so forth. That's just this is the micro assessment question, is I trust this trainee to perform this EPA with, you know, what level, and then the graduation standard being a 4 or being practice ready, which also aligns with the milestones. And then for us, it's really just the beginning. We have continuous quality improvement built-in reevaluation to determine if we should modify, revise, add, delete anything over time. And we'll do that on at least an every 5-year basis. So certainly we're going to engage in that, similar to the general surgery strategy of shortly after the pilot study, and compare to our curriculum, our fellow case logs, graduation requirements, et cetera. And then our pilot study, which was just funded by our association. So programs are going to be invited, but not mandated to collect assessments. We'd like to target 1 per clinical day for each of the fellows. And thinking that if we shoot high, then maybe it'll motivate people to do quite a bit. We'll have a toolkit available with training materials and assessment tools, and putting together similarly a central data repository for semi-annual submission. We want to know if this is feasible during fellowship, what % of our trainees achieve entrustment and in which EPAs. We want to compare EPA assessments to our current methods, and then compare entrustment levels between endocrine surgery fellows and general surgery residents, because as we continue to build out EPAs for general surgery, there will be overlap at the very least with thyroid and parathyroid disease, as that's continues to be a core component of general surgery. And so with that, I will stop, and I'm happy to take any questions that you may have. Thank you again very much.
All right, thank you, Bernissa. It was really very informative talk. Thank you so much for sharing your experience. So but I was particularly interested in hearing your thought because of, you know, our specialties, similarity and differences. So one thing which is common to our specialties is we're relatively small and we don't have that many disease processes as compared to general surgery's big envelope. The differences, however, are I believe your training is 1 year, ours is 2. And second is our ACGME is pretty heavy on our milestones and not yours. So as in, like, you know, you can add to your list of things. We have to subtract, I think, something. So I think from your talk, what I learned was that when we embark on making our our EPAs, milestones matching is something for which in-person meetings would be suggested, right? What other lessons do you have for us for a specialty of our size?
Yeah, I think the big thing that I learned, and perhaps this was all done prior to when I started with the general surgery group. You know, I sort of walked in and the 5 EPAs had already been selected. But what was so helpful for us was going back to our fellowship requirements and then also ensuring that what we chose aligned with what our fellows actually do. Because there was the temptation to include things that, you know, some person had a practice that had a lot of you know, adrenal malignancy. And they're like, well, I mean, we see adrenal malignancy a lot. And then everyone else is like, well, no, not really. And so finding the actual data to say what our trainees are doing and what we would have the opportunity to observe them, you know, working toward entrustment on was really important for our discipline. And it took a little bit to get that data together. And so hopefully, I imagine that you have probably more of an organizational structure and centralized information, but I think that'll be something that I would highly recommend as you move forward.
Can I chime in with a question? Faisal, I know you're moderating this section, but I was just wondering, it crossed my mind if there's any reason we need to be considering the differences between our integrated residency and our fellowship. What implications does that have for how we develop EPAs in vascular surgery?
Yeah, and that's such an interesting and important question, and puts me in mind really of, you know, the thoughts that we've had around endocrine surgery fellowship and the general surgery residency. You should write your EPAs. Now, others may disagree, so I welcome others' comments, but I would suggest that you should write your EPAs to be the tasks of a vascular surgeon. And then that's the mark, that's the floor that you expect everyone to get to. And so, you know, your vascular surgery fellows may start at a higher level of entrustment as compared to where your integrated residents will start, because your integrated residents are starting, you know, brand new out of medical school, but the end goal is the same. And so I would say there is no difference in the EPAs. Just the place that people enter the pathway.
Other comments, Dr. Cirosi? I think you're...
Yeah, no, I actually started typing that comment because that was one thing I wanted to mention and I'd forgotten. And I think that's a challenge with vascular surgery, right? Because you really have 2 training pathways to the same certification. And so wearing my ABS hat, right, you probably need to have the same EPAs for both pathways, because at least in the ABS vision of this, the EPAs represent the clinical competency assessment and training that is necessary to be able to sit for certification. Now, I think it's a big challenge, right? Because they're clearly 2 very different, you know, a first-year vascular fellow from in an independent program has completed 5 years of general surgery and theoretically will have gone through all of the general surgery EPAs at some future point, whereas the integrated resident will have ideally done the 13 EPAs of graduating medical school, but will probably have none of the surgical ones. And so, you know, it may be, as you think about them, that seeing what the set of general surgery EPAs looks like will be helpful. It may not. And, you know, it may be that you'll have some EPAs that cover, you know, basic patient care for a patient with vascular disease that aren't as procedurally based. I know that in Canada for the general surgery EPAs, there are sort of two sets, right? There are the foundations of surgery EPAs, 3 sets, right? And then which are the first couple of years, and then the specialty EPAs, which people finish. And I suspect, we'll hear about that from April, hopefully. But I think that is one of the challenges with specialties that have 2 pathways to training. Is theoretically everybody should complete the same EPAs, although that may be a challenge. I don't have great insights on that one.
No, it's a very interesting topic for us, for programs with both 2-year and 5-year pathway. I think Dr. Bichara, you have an interesting question in the chat. Dr. Cirosi and you yourself have been chatting about it. Do you wanna share with the live audience as well, so we can talk about it?
Yeah, interesting discussion. I'm learning a lot, so thank you, everyone. Well, I mean, should each center, Dr. Lindman mentioned, maybe MD Anderson might do some more complex cases some other places. So should each institution have its own EPAs? Like, should we have a basic? Because at the end, we want to make sure we graduate a competent vascular surgeon. That's the goal. That's what, if you want to hire someone, you want to make sure you hire at least a competent vascular surgeon. But for these other, centers of excellence or high volume centers, should they have basic and individual center-based EPAs?
So the way I would answer that is to say that your specialty needs to have a set of core EPAs that all people that graduate from training and that will go into practice and be called vascular surgeons need to demonstrate entrustment in those core EPAs. And then I would challenge you or the leaders of the vascular surgery board or whomever is making this decision as to whether you want to sort of create formal elective EPAs that some programs, maybe a menu they want to select from and say like, okay, this program's going to offer these elective EPAs, or, we're going to offer these other different ones. But what I suspect will happen, because this is what's been happening with the medical schools, right? So the medical schools have had these since 2014, and there are 13 that they all have to, they're not mandated yet. So there was a pilot, but most schools have sort of adopted them. And then, all the medical schools want to differentiate themselves. And so they've gone back and they've said, well, we provide this excellent training in rural primary care. So we have an EPA around rural primary care for our graduates, or around simulation, or, whatever it is that is that school's sort of hallmark. And so, and the medical schools use those to sort of advertise what makes them different from others. And so we have chosen an endocrine surgery to sort of bring that out and say, these are the options for elective EPAs. Programs may or may not be able to offer this, but I think that's a decision that I would encourage the leaders of this effort to make consciously and deliberately.
I think
the way I look at
sorry,
go ahead.
I think one of the other things that's really nice about the EPAs is that the difficulty and the complexity of that patient or that procedure is sort of built into the EPA itself, right? So when you evaluate a resident or a trainee on something that is fairly simple, they're going to probably receive a higher level of autonomy on a straightforward lap appy than they are on something that's perforated, and that's okay, right? Over time, their microassessments should continue to kind of bounce between 1 and 2, and then 2 and 3, and 3 and 4, until they're all the way up at that highest level of autonomy where we think they are entrusted to take care of that patient. And I think the same thing would be true for vascular, right? You might have residents who are or trainees that are very capable of taking care of elective, straightforward, I guess, AAAs, but not yet ready for the rupture, right? And so over time, they will get competent in both. And so I totally agree with what Pranessa said, that like, think about what the floor of a competent finished vascular surgeon is and write them for that. And then the complexity will come out in those cases and those assessments over time.
Yeah,
I agree with that. I think already do that for example, for ACGME, case requirements, for example. Even today, EVAR is included, but not fenestrated endografts or not physician-modified endografts because, that's the national baseline floor. So I think we should probably look at the same way. I'll refer to Dr. Huber and Dr. Shames to see if they had any different thoughts.
Well, I don't think we want to make this totally procedure related, right? So, you're not going to have an EPA for complex, for fenestrated EVAR, but you might have an EPA for complex aortic procedures, right? And that might be an open thoraco or a fan. Like, I see April nodding. So obviously they figured this out already. And so we'll have to wait till the end to get the answers. But, again, this is not a marketing tool for Loyola's aortic program. It is a assessment of our training program. And I know that, you're awesome. So I think it would be something that the trainees would look at potentially as, well, this is something I might be interested in doing, and this is something I know I'll learn there, which is what they do now, right? But so, I think it's important that we focus on all of these facts. But this has been really great. That was really interesting in the sense that, like, you could really break it down into the 5 organs that you take care of. Like, we really need to start thinking of that way rather than every detailed operation that we do, because we're never gonna, I see Tom thinking, like, how are we possibly going to coordinate that at the VSB, checking them off on 274 independent operations?
Yeah, not a chance on that one. I think to kind of echo what's already been said, we are defining a set of skills or EPAs that we should say every vascular surgeon should be able to do. And out of every program, they don't have to be doing abdominal aneurysms. They don't have to be fenestrated endografts, but they do need how to take care of an elective aneurysm. They know how to take care of some of the acute lower extremity ischemia. It's that core group of skills that everyone needs to do to call themselves a competent vascular surgeon.
It's a great conversation, guys. I know we're running short of time, but Dr. Conway asked a very interesting question, which I think would merit some discussion. Dr. Conway, you want to ask the question that you wrote?
Thanks, Faisal. I'll keep it brief so we stay on time. If trainees are kind of on a 5-year program and they get told after 3 years or whatever that they've met the EPA for certain procedures, have you experienced trainees becoming disinterested, trainees disappearing, or do the trainees kind of keep working and then training their junior colleagues? What's been the experience?
Well, we're not there yet. Obviously, we've only piloted it, and so we won't probably know that until sometime in the late 2020s if we start. I think the one thing that I would say in the current vision at the ABS level would be, so you'll be assessed across the EPAs, and our initial mandate is just that you're assessed across there. We're not going to specify a graduation level, although one would assume that if you had a trainee who required direct supervision to do a gallbladder, you wouldn't be willing to forward that person for certification. They will also be required to generate a case list, because I think that at least in the framework that we have right now, the EPAs will be a competency-based assessment, but they won't assess everything. And I think as you think about, someone who's capable of practicing in a specialty, you want to sort of do a deep dive on those critical elements. But I think one of the other things that is important is that they have sufficient breadth of training. There are many things that are actually important in general surgery, like doing a splenectomy, that actually we assume everyone could do, but nobody actually does enough of them for us to watch them all and verify that someone's capable of doing it. This is a problem when people get credentialed at hospital levels for this. As a general surgeon, I'm credentialed to do a splenectomy, but I might do 1 or 2 every 2 years of credentialing cycle, which they would say are not. And so I think that one would hope that that trainee would still have the rest of their case list to get done, because the RRC currently requires a breadth of case experience at the programmatic level that you have to have them meet, or they generate citations for you. It doesn't affect their certification, but it obviously affects the program standing. And so one would hope that would be the case. I would say that if someone checked out after 3 years and sort of basically just dialed it in, I'm not sure that person's entrustable, right? And so I think that, that would be the lever that I would see. Even though they achieved clinical entrustment, they might demonstrate a disturbing lack of professionalism and motivation that might not make them entrustable.
I agree completely. And what I would add to George's comments, because I was thinking along very similar lines, is just that we've talked about this a lot on the revision committee for the existing 5 general surgery EPAs, is that our 5 EPAs are very basic. Like they're really, many residents would probably be fully entrustable in like the 3rd or 4th year of residency training. And so we're not likely going to see people complete entrustment with these and check out, because they have a lot more advanced skills that they are still working on, to his point about the case list, right? They're going to move on and focus on doing Whipples and esophagectomies and total colectomies and aortic aneurysms, other complex cases.
All right,
Sounds
with that,
good.
I
Thank you
think
so
it's,
much.
yeah,
Yep.
sorry, Faisal, didn't mean to interrupt you, but I think with that, it's time to wrap up for a little break. I really appreciate everyone's engagement in the conversation. This has been wonderful. We have 2 more outstanding speakers coming up. We'll take a 10-minute pause, get some water, et cetera, and then we'll learn from the program director's perspective, more practical tips from Dr. Greenberg. And also I've learned some really great things from Dr. Boyd in Canada and the approach they've taken. There's some important learning points. So come back in 10 minutes and we'll wrap up with 2 more speakers. You ready, Jake? Cool. I'll introduce you in just a couple seconds here. We'll let it wind down to 2:30 and then we'll launch.
Sure.
You can go ahead and share your screen.
That look okay? Not in presentation mode, hopefully?
Yes.
Yep, you got it. Every time I do Zoom, I figure out a different problem, which that was the best part of the afternoon. Dr. Eit drew a red line across someone's slides. How do you do that?
No, I asked him. It was pretty cool. I thought he was on his iPad. So apparently on iPad you could do that. I mean, that's like Zoom bombing, you know?
Yeah.
But I thought it was pretty
All
cool.
right. Well, it is 2:30 Mountain Time. I'm probably the only one on Mountain. 3:30 Central. So we'll kick off the last couple of speakers here, and it is my pleasure to introduce Dr. Jacob Greenberg, Professor of Surgery and Neurosurgery and Assistant Dean of Surgical Competency Assessment at the Medical College of Georgia at Augusta University. Dr. Greenberg received his MD from the U of Pennsylvania and Master's of Education from Harvard. He completed general surgery residency at the Brigham, followed by a minimally invasive bariatric surgery fellowship at the University of Massachusetts. He previously served as the Associate Program Director and then subsequently Program Director for the General Surgery Residency at Wisconsin, where a lot of his experience with implementing EPAs comes from, and was also the Program Director for an advanced fellowship at UW. He's the PI on a $1.1 million grant from the Wisconsin Department of Health and Human Services that supports residency expansion into rural training environments. And he's also an author on numerous publications related to development, implementation, and use of EPAs, as well as an author on my very first ever educational publication about vascular surgery programs way back in residency. So we go way back. Welcome, Dr. Greenberg. Thanks so much for being here.
Thank you, Bridget. It's incredibly kind, and it is really awesome to see how your career just continues to progress. It's we are incredibly proud of you. I do want to say that the professor of neurosurgery is absolutely fake advertising. Much like John Reckenwald, I now work for my wife, as she is the chair of the department here, and so I sit in the Department of Neurosurgery, but I know absolutely nothing about it, and probably very little about regular surgery as well. So thank you for the opportunity to share our experience. I'm going to talk about all the work that we did at the University of Wisconsin during really the ABS pilot and now beyond. But as you know, Dr. Cirosi kind of mentioned, the experience was really highly variable between institutions, and I think there were a lot of things that helped our institution sort of flourish for this that were just naturally occurring events. So I think we were a little lucky and well positioned to do well with this. But I think that there are really multiple pathways to success for implementing this into training programs, and unfortunately, I think also multiple pathways to failure. So I'll try and go through what I think worked well at UW and what some of our challenges were and what we were able to do to try and overcome them. So as George mentioned, the pilot study kicked off in 2018 and ran from 2018 to 2020. And essentially within that program, there were 28 different general surgery training programs selected to pilot and implement those 5 EPAs. George already kind of went through the breakdown. There were a mix of academic and independent programs, and each program was responsible for implementing 2 of those 5. The primary outcome in the study was entrustment decisions for each resident, and those were taken at the CCC meeting. And then the secondary outcomes were the number of microassessments and the milestone evaluations. Beyond that, I think one of the things that the board did really well in this study was that there was really no guidance and no rules. This was a chance for each program to try and innovate, think about what their institutional environment was and come up with solutions that would work for them. And then at the end, we could go back and look at the bigger pool and see what worked, what didn't, and what might be best practices for a variety of different programs. So it was a very open-ended study, and everyone was just told to, here's your 2 things, have at it, and figure out what you're going to do. And so when I started talking with Rebecca about what we were going to do, you know, there were a lot of emails that Simple was going to change to be able to do EPAs, and I thought that would be a fairly easy way for us to kind of get involved in this since we were already using it. And Rebecca, very much to her credit, said, no, that's not really innovative. Let's do something different. Let's figure out what's going to work for us. And so we're not going to use Simple. We're going to do our own thing. So that was kind of what I was tasked with as a program director. So of the 5 EPAs, which I know that George and everyone else has sort of already shared, we were assigned these 2. So the evaluation and initial management of patients presenting with blunt or penetrating trauma, and then provide general surgery consultation to other healthcare providers. When we looked at those 2, that really put pretty much all of the pressure for EPAs on our trauma and acute care faculty, because they are pretty much the only ones that do trauma. Our peds surgeons do as well, but all of the elective general surgery subspecialists, such as myself as an MIS surgeon, don't take any care of trauma patients. And most of the general surgery consults come from the ER, from the medicine services, directly to our acute care surgery service. And so rather than putting all of our eggs in that basket, we decided that if we're going to do this, we should just go big or go home. And so we decided that we were going to implement all 5 of them. We're going to build the app to work. We might as well build it for everything. We're going to implement all of these anyway at some point. So we just decided to do all 5 and try and get as many faculty members engaged and involved from the beginning as we could. And also to give the residents a broader option of cases and diseases in which they could fill out EPA assessments and micro assessments for themselves. So the first step for us was building an assessment platform. We kind of immediately thought that a paper platform was out, right? There was no way that that was going to work. We thought that potentially doing something on Qualtrics would be feasible, but it would require you to sit down at a computer, log in. It would take a lot of extra steps. And we wanted to make this as sort of seamless, painless, and easy as possible. We happened to have 2 people who worked in our IT department for the department, Richard Nelson and Sean Martin, who had previous experience working on apps. And so we tasked them with trying to help create this platform. I worked a lot with them on what this would look like, but really they did all of the work. I kind of said, this is kind of what we want it to look like. This is what I envision, and they operationalized it. And I know that Rebecca already showed her video, so we don't need to show that again, but kind of the key features of the app were that it had the ability to both push and pull the micro assessment. So after a case, if the resident initiated the assessment, then that assessment would get pushed to the faculty member associated with that case for them to complete. And when you open up your phone, it looks like you have an unread text message or an email. You get that little 1 above it, and if you turned on your banner notifications, you would get a notification just like you do from your calendar that you have an assessment to complete. Similarly, if the faculty initiated the assessment, it would then go to the resident and they would get the same notification. We wanted to make sure that people were assessing the same cases. So we also wanted to make sure that we didn't include any PHI here because we thought that that would be very difficult to get through from a HIPAA compliance standpoint. So the app auto stamps the date and the time that the assessment is created, but it doesn't necessarily tell you which case it's for. So for example, if I did 5 inguinal hernias that day and the resident waited until the end of the day to push out all 5, I won't necessarily know which one of those micro assessments is associated with which of those cases. So we tried to push people to really do them in real time. So as soon as you're done the case, fill out your assessment so we know which one is which. We also wanted to make sure that it was still fresh in people's minds. So if someone completes an assessment and it gets pushed to the other party, if they don't complete their version of the assessment within 72 hours, it gets wiped from their slate. And that again, just got rid of some recall bias and got rid of us potentially filling out assessments for cases that we don't really remember. We wanted it to be fresh in time. So they did delete after 72 hours. A little bit into the study, we realized that because of that deletion within 72 hours, we were losing a lot of data. So our app developers went back and created a nightly notification. So at 5 p.m. or 6 p.m., I think every night that you had a pending assessment to complete, you would get a banner notification on your phone. So not only would you get it when they initially complete the assessment, but the app would kind of key you in that you have some more work to do at 6 p.m. at night. Only during the weekdays. We didn't really want to burn people out. So that helped to improve our response rate as well. The assessment time was the key here. We wanted to make sure that this was a really easy and really straightforward thing to do. So even in the early phases of where you're trying to figure out how to use the app and read through it, it really only took at a maximum 2 minutes. It was very quick. It was very easy. You could dictate in feedback or type it, whichever you preferred. And we wanted to make sure that this was like a very small time suck for both the residents and for the faculty. The last thing we did was we tested this like every possible way before we rolled it out, because we wanted to make sure that once we rolled it out, we had gotten rid of all the bugs, because I kind of thought that if we roll this out and someone gets unhappy with it on their first use, they're never going to use it again, right? We're asking them to do something new. We're asking them to do more. And so we wanted to make sure that this absolutely worked. And so before we kind of pushed it out to everyone, we went through several rounds and iterations of it and made sure that it was pretty seamless before it went out. As we were working to develop the app, we also recognized that we had to do some pretty significant faculty and resident development around EPAs. Now, I am sure that, that Rebecca thought about this. And so prior to the academic year of 2018 to 2019, we have a departmental education retreat every year. And the education retreat for the prior academic year, which happens usually in May, so kind of right leading into when our residents changed over, was completely on EPAs. Gurjeet Sandhu, who is a PhD educator from the University of Michigan, came. She gave 2 lectures on EPAs. We did a lot of faculty and resident workshops on EPAs during that sort of one-day retreat. And so it was already in people's minds even before we hit the ground running with the pilot study. We then took the first didactic resident session of the year, which is 2 hours of protected resident education time on Tuesday mornings. And we made that a resident training session. So for those 2 hours, I sat down with all the residents and we went through the clinical vignettes and behaviors of the EPAs. And we did it using this sort of jigsaw methodology, which came from Sarah Jung, who was our PhD researcher. So in that, we split everyone up into 5 groups. And so we had everyone initially sit by their PGY level, and then they counted off 1 through 5. And so in each group, there was a PGY1, a PGY2, a PGY3, a PGY4, and a PGY5, and sometimes multiple of each. So each group had representation from every PGY level, and each group was assigned to learn one of the behaviors and clinical vignettes of one entrustment level. So Group 0 learned the behaviors of people functioning at entrustment level 0. Group 1 learned the behaviors of people functioning at entrustment level 1, and so on and so forth. It was also a way for the residents, especially the new residents, to get to meet their colleagues, which they had not really previously met. It was like their second day on the job. Once they had mastered those entrustment levels, you then recount off into groups. And so each group then counted off A through E. And now you have someone from each different entrustment level teaching one another what the progression of entrustment is from level 0 all the way up to level 4. So the residents really kind of familiarized themselves with all these different entrustment decisions. And then we had them come back at at the next day's grand rounds in M&M. We took that 2 hours and used that for a faculty development session. And we did the same exact thing, but we had the residents teach the faculty. So again, this functioned as a way for our new residents to meet the faculty and to really get everyone on the same page and develop a shared mental model of what the different behaviors at the different entrustment levels look like for all of these different EPAs. The other thing that we did when talking to our acute care staff, who were again the ones that were going to do the majority of the trauma evaluations as well as the consultative evaluations, they really recognize that they don't see a lot of the behaviors during those traumas and those consults, right? The residents go and see a consult, they talk to the attending about it, and then they have to go back and talk to the consultant or the person that requested the consult about what our plan is. And so a lot of the behaviors that were written into those EPAs were actually being seen by the emergency medicine physicians and not by our trauma and acute care surgeons. So we actually extended an olive branch to the Department of Emergency Medicine as well as our Division of Hospital Medicine and asked them to be partners in this with us. We asked them if they would feel comfortable evaluating our residents on those behaviors that we don't explicitly see, and they do. In return, we also said that we would happily evaluate their residents on the same. So for those behaviors that we do see when they're doing procedures in the trauma bay or other things that our attendings were overseeing, we would commit to doing those evaluations with them. And it actually ended up being a very nice working relationship with those two groups, but predominantly with the Department of Emergency Medicine, who has been a great partner in this with us. So we sort of hit the ground running in August of 2018. The first month, I was hoping for a huge number of micro assessments, and my ego was a little broken when we got about 50. But I think it was just sort of ramping up. And then the second month, we had about nearly 200, which to me felt like a pretty good accomplishment. And then, not surprisingly, there was just this natural decay. If we didn't kind of keep constant pressure on, things would dip back down. So over the course of sort of the first year of the study, we would vary between about 50 and sometimes close to 200 micro assessments per month. Our peaks there seem to be associated with sending out monthly reminders. So you would send out reminder emails to everyone. That I included a very granular leaderboard of both faculty and residents so that they could see who was doing this and who wasn't, and create a little bit of competition. When we would have educational grand rounds, particularly ones that focused on autonomy and entrustment, we would see those numbers bump up. And then with the excitement of the turnover of the academic year and new people coming in, we would tend to see a little bump up as well. I think the bigger challenge here was when we took this data to the Clinical Competency Committee. So our Clinical Competency Committee would meet every 6 months. So we would meet in December and we would meet in May or June. And at the first Clinical Competency Committee, the overwhelming majority of EPA graphs for our residents look like this. Right, so even though we had sort of several hundred micro assessments with 54 residents, each resident maybe had 5 or 6 or 4, and it might be 4 scattered across 4 of the different EPAs. So we had very little data to go on the first one. So I was kind of at that point, 6 months in, I was very doom and gloom. I kind of thought that this was never going to work. But as time went on and there was more time to the study, and at the 12-month and 24-month period, you started to see graphs that look like this, where you could actually make real meaningful entrustment decisions based on data. The other thing that we did, and the reason why I included these graphs, is we blinded ourselves as to who the resident was that was being evaluated. We found in the first one, when we didn't do this, we stopped looking at the data and kind of like just used the gestalt of, yeah, I think that resident is probably fine to do this unsupervised for appendicitis. I've seen them do it, right? We decided that we wanted this to be really a data-driven study. And so we started to blind all of the data. We would then take the CCC, we would go through all of the data for every resident first. We would make our entrustment decisions. And then when we started to do the reviews of them to fill in their milestones, we would unblind this data and say how they performed on each of the different EPAs. And that way we could at least talk about if we thought they knew their limitations. And anecdotally, I would say that their EPA performance did really track well with our sort of overall view of their performance on the milestones as well. At the end of each CCC meeting, I would then publish this to all the faculty. So all the faculty would get an email that had every single resident listed and what sort of entrustment decision we had made. And my hope in doing this is that the faculty would say, okay, well, resident so-and-so is approved to have indirect supervision for patients with inguinal hernias. So when they come onto my service and do an inguinal hernia, instead of showing them how I do it the first time, I'm gonna let them take the reins much sooner. I think most people didn't really either pay attention to this email or quickly lost it. And so we went back to our app developers and asked the app to basically do this themselves. So the residents now have the ability to walk into a case and say, hey, I am entrusted at level, or here's my data for, right lower quadrant pain. Let me do this API. Or it sort of empowered them to show the faculty where they were and their level of performance, and let the faculty make a little more data-driven decision about how much or how little autonomy they were going to provide for cases. So with all of those changes in the beginning of year 2, we started to really seemingly pick up, right? When we look at this graph with the new academic year, we are on a pretty good slope here. And now we were getting over 200 microassessments. And then March of 2020, and we got absolutely just crushed by COVID. Now, part of this was that, you know, we were back then changing services, we were sending residents home. It was just a big change. So I'm honestly even surprised that we continued to have any performance during that period, but it definitely had a significant effect on our productivity. I think the one thing that it also did was it showed that the faculty here, who is in red, it took the faculty a little bit of time to get used to this, but as that time went on, the faculty kind of got this integrated into their workflows. So while we did a lot of upfront work and we're hoping for great outcomes from day one, it just took a little bit of time for this to become ingrained in faculty's day-to-day lives and as part of their practice. And so I think Rome isn't built in a day, and it just takes time for people to change years and years of their practice patterns and to adopt something new. So don't be surprised if implementation definitely takes some time. And again, when we look from year 1 to year 2, our total number of assessments submitted increased by about 300, but really a lot of that increased on the faculty side, and the response rate of the faculty improved as well. So it just took a little bit of time for this to get ingrained into people's activities. One thing that we did see, and I apologize, I know that this is a very busy, very small slide, but what this is showing is this is our program percentiles in the ACGME defined category report. So if you look in this column, this is where UW stood compared to every other general surgery residency in the program in the defined categories. And we looked at the number of teach assist cases, which are cases booked by senior residents that are taking junior residents through those cases. During the 2 years of this study, prior to it, we were in the 77th percentile. And then in year 1 and year 2, we moved into the 91st and the 94th percentile. So I think focusing on autonomy and entrustability, I think made the residents and the faculty feel more comfortable letting residents be more autonomous and taking junior residents through cases, whereas historically that had not been the case. So I do think it helped to move the needle on this pretty significantly. So I want to leave a lot of time for questions, but I think for us, some of the keys to successful implementation were, it was very helpful for me as a PD to have a department chair that was all about this, right? Anytime I would send out an email about it, she would immediately reply to all and was an absolute champion. So I think having clear-cut alignment between our chair and myself as the program director was really instrumental into our success. I think it showed the faculty that this was important, not just for the residents, but also for the department. So I think that was a major plus for us. We again had yearly education retreats. So we had touch points throughout the year where we just had a focus on this. So it stayed part of everyone's sort of in front of everyone's mind throughout the 2-year study period. And we really tried to highlight that EPA performance as frequently as possible. At every division meeting, I would spend time talking about this. I would frequently go to the divisions throughout general surgery as well as to the emergency medicine and hospitalist division meetings. Just again, thank everyone for their work, to thank them for their collaboration, and to continue to try and motivate them to keep doing this. So it took a little bit of personal effort as well. We also developed a pretty good research collaboration with the Department of Emergency Medicine. Again, we were evaluating their residents, they were evaluating us, and so we were able to publish a number of papers with both faculty members from EM and surgery as well as residents from EM and surgery represented as well. So I think both departments saw that it was beneficial not only for resident training, but also for academic careers. One thing that we recognize is that when the new incoming interns come in, they have no idea about this, right? So every year you have to like reground your people in this because the incoming interns won't know what to do and won't know what to expect. We didn't think about this at the end of year 1, but our residents that were transitioning out of their 2 years in the lab also knew nothing about this. They had really not been involved. And so we thought about it a little bit late, but then we recognized we had to have an orientation session for them. So if you have a training program with lab trainees and you start this, just remember when they come out, they might need to be grounded in the subject material as well. The monthly emails were definitely motivating. Again, I would send out an email that sort of looked like this, right? So the residents would see exactly how many people had submitted. And more importantly, we would send out ones to the faculty that would show what their response rate was and how many they missed. And I would very intentionally try and highlight our people that were doing well. So these were our 100% performers. I would particularly highlight Dr. Ken Kutz. Ken is one of our trauma surgeons who now mostly just works at the VA. Ken is like 67, 68. When we started this study, he only had a flip phone, so he couldn't get the app. So he was doing this on paper and then would submit it to our program coordinator, who would then enter it into the app. He finally got a smartphone in like 2019 or 2020 and learned how to use the app and do it, and was like one of our best performers. And so I would highlight Ken and say, look, if Dr. Kutz can do this, there's absolutely no reason that everyone else can't. And then being a deeply competitive person, I would absolutely highlight the fact that I was crushing this and beating everyone and told them to come get me. If you're not first, you're last. So I would challenge everyone to try and beat me every month too. And would lose some months, mostly to David Melnick and to Ken Kutz. Again, we would do the same with the EM faculty. We wanted to thank them for being partners in this. And so we would highlight them on that same email, and it would just go out to everyone. And routinely you would get people saying like, you know, I don't know why I'm missing these. Like, what can I do differently? And I think it was a little bit of competition was very motivating for people. So I think this helped. I think our roadblocks were some of the things that are challenges that we've talked about already today that are particular to general surgery that might be significantly easier or better for you guys in vascular. So the scope of general surgery was a problem. We are at UW, it was a group of really subspecialized surgeons. And so, you know, I was in the MIS section. My wife is a breast surgeon. We have endocrine surgeons. We have HPB, and we have colorectal. And a lot of those faculty had 0 cases that fell within one of the 5 EPAs. And so they might occasionally take general surgery call and potentially be able to complete one of those API or coli ones, but it's just not part of their workflow, because if you're a colorectal surgeon, you're not doing this on a day-to-day basis. So there were only sort of pockets of faculty who were consistently able to do it. And I think that hurt people because it just wasn't part of their day-to-day workflow. Similarly, our residents would rotate off of the services like acute care, where they're doing a ton of these, onto something like surgical oncology, where they're doing none of them, and they would lose momentum too. So not having sort of a full suite of EPAs, I think, was difficult. And I think for you guys in vascular, having a smaller scope of practice will be much better. I think it is hard to ask people to do something that's additive rather than replacing. So, you know, you're asking people to fill out more evaluations, but still complete the end of rotation. I do think the ABS and the other parties are cognizant of this. In fact, the ABS is accepting their EPA micro assessments in place of 6 operative case assessments and clinical assessments that residents need to complete for their boards. So instead of submitting these 12 things that you have to ask new faculty to get or to complete for you, like if you have 12 assessments from the EPAs, you're done. The other interesting thing was that, you know, that we really tried to empower this to be a learner-driven thing. That's what the EPAs are supposed to be. The residents are supposed to be driving this. And our residents, I would assume like yours, like their major complaint on our ACGME survey every year is like lack of feedback, right? They're not getting enough feedback. And so we gave them an app to get more feedback, and some don't want to do the extra work to get it. So despite empowering them, it still is something that you have to kind of push them forward to do pretty frequently. So, so it's one of the other things to consider. I think to overcome some of those roadblocks, things that we decided to do. So I mentioned earlier that the Fellowship Council wrote a number of EPAs. We went through those EPAs and said, okay, well, our residents do a significant number of these cases. This will stretch the EPAs out to potentially more faculty members and give more people an opportunity to use the app and more opportunities for feedback for the residents. So let's implement these too, right? They're written for fellows, but a lot of these are cases being done by general surgery residents. So even though they're not specifically written for them, let's start using them, right? The bigger and broader and more EPAs that we can include, we thought the better we would do. We also had been doing both simple for certain cases and using our app for EPAs for the other. And we decided that it was just becoming too much for the trainees, right? They had to go to simple on some services, ours for another. And so we basically just created this generic micro assessment. So the residents could write in any case and just ask for what level of sort of entrustability they had for that specific case. Now, there were no behaviors. It's not a true EPA, but it was sort of an operative assessment and an opportunity for you to give them some feedback about what they did well or poorly during that case. And again, it drove everyone to one app. It gave everyone the ability to use one program, and it just kept it more in the front of the residents' minds that they can ask for feedback on every type of operation. So it's not really an EPA, but it was a tool to help try and drive more use of the EPAs when residents were on services that were doing them. And I think the board has sort of recognized this as well. And as George mentioned, like the board is trying to write a full suite of EPAs that will come out by July of 2023. And there are a variety of different groups that are currently working on the writing of the EPAs, the review of the last 5 EPAs, and then figuring out what sort of the best practices were from the 2-year study and how we're going to implement those into programs. So I think you guys sit in a really unique position. I think as Bernice has highlighted, that having a smaller faculty and a smaller scope of practice, I think will really be beneficial, right? So all of your faculty members will have the opportunity to start these assessments kind of from day one. Your milestones are more procedure focused than ours. I love the one that you have about intraoperative crisis management. Like that's awesome. Ours are much less specific than yours. And so your milestones sort of already lend themselves to transitioning to an EPA, whereas for ours, it was definitely a little bit different. The other thing is you guys have a stronger longitudinal relationship with your residents, right? Like you work with your fellows for 2 years straight completely, and you work with your integrated residents for the overwhelming majority of their 5-year stint. Whereas even as the program director, I would get most residents for a month as a 1, 2 months as a 3, and 2 months as a 5, right? Like they go off service and they don't come back for long periods of time. Whereas they never really rotate off service for you guys. So you'll have that opportunity to continue to assess them on a day-to-day basis for sequential years. The smaller faculty, I think, can also be a barrier, right? Like if you can't get buy-in, it's just going to fall dead. So I think that you have to do that really well if you continue to move forward, which I applaud you for doing. With fewer trainees, I think it's going to be very hard to blind your data. You probably could if you're, if you have an integrated training program in the residency, but if you have like 1 fellow every year, and you have 2 people, you're probably going to know which one's which. To be honest, I don't know that blinding the data is all that important or necessary. I think it just got rid of some of the usual sort of clinical competency committee talk where we think of people based on our last experience with them, and it really focused us to look at the data. So I certainly don't think it's necessary, but we sort of found it helpful. This is a little bit more work, and I think that and the change in people's sort of day-to-day practice and their normal workflows is probably the biggest hurdle or challenge to overcome. But I certainly think that you guys are well poised to do it, and it's really exciting to see this moving forward in your specialty. I think you have a really tremendous opportunity here, and happy to take any questions.
Thank you, Dr. Greenberg, for sharing your thoughts. I really enjoyed your talk. One reason, because every question which I had, you pretty much answered most of the questions while you were going over the talk. And the real fun of listening to you talk was the practical application. That's where we need to learn. So I do have a question. I mean, needless to say, you need institutional buy-in. You need, your leadership to buy in the whole concept, to have some support. It looks like you spend a lot of time, right? To convince people and to go to the meetings and to talk with the residents. Did you, for your own sanity and your own time set, how did you do that? Did you ask for more time? Did you ask for more FTE? Personally, how did you manage it?
I just added it on to the schedule. I would start clinic late if that was the only time that the Department of Emergency Medicine could meet. I'd block off a little bit of clinic. I certainly tried never to cancel cases or do anything like that, but just tried to make myself a little bit more available than usually I would be to try and get this up and running. Once it got up and running, it got a little bit easier, right? It was a lot of upfront work. But again, a lot of that is because our our department was set up in a variety of different divisions, and I had to try and go to each of them, right? Whereas you guys are working all within the same division, and I think that will make things a little bit easier. If you do decide to write EPAs that involve potentially evaluators from other specialties, that will be something that you have to think about. Like if you want to have a vascular surgery consultation EPA, you might want to check in with your emergency medicine or your internal medicine colleagues who are going to be the source of those consults, because they're going to see a lot of the behaviors that center around sort of communication, interdisciplinary communication, that we in surgery just don't tend to see, right? We don't see that aspect of our trainees. In fact, when we look, and I think Rebecca shared some of the data, but when we looked at the different evaluations, one of our residents used natural language processing to look at what surgeons evaluate or say during their feedback versus what the EM people talk about. And we talk about procedures, right? Like we talk about skilled in the OR, good hands, great technique. They talk about excellent communication, timely feedback, like close the loop. They focus on very different things. And so I think it does give a better total picture of what the training actually is to involve some people outside your own specialty.
Thank you. Bridget, I think you have a question.
Yeah, I mean, I think it's generated a lot of discussion in the chat already, but some of the questions were surrounding the app that you developed, whether it's scalable for others to use, and kind of how things went for the programs that chose to partner with Simple as an alternative.
So I think Rebecca is currently working on trying to make that more widely available. And I think part of the hope is that maybe the ABS will adopt that type of app or something similar. And that it could be either used or housed at the ABS or potentially still housed at Wisconsin and then licensed out. So I do think that that will be scalable. Certainly now here at MCG, we're hoping to be one of the first test sites to start using that as well. You know, I think I can certainly see what George and Bernessa want to comment, since they, I think, use different platforms. People use new innovations, people used Simple, people used a variety of different things. And I think many of them felt successful with them. And I think, again, it just depended on what was available at their institution. Bernessa or George, you guys have anything to add?
I would say one of the things that you have to think about is we tend to focus on the collecting of the EPAs, but honestly, the ability to kind of pool the EPAs and analyze the data is actually probably more important. Because I think that, you know, you could just have people fill out paper forms. One of the programs in the pilot actually was really super clever, and they created Google Doc forms that were scaled to look good on a cell phone, and they basically just collected Google Docs. We use Simple, and our failures had nothing to do with Simple and had everything to do with faculty development, which I do think is really important. I know Bernessa developed her own app, and I don't know if she wants to comment on that.
Yes, happy to comment. Would say definitely I didn't develop it. We worked with a competitor to Simple, basically. It's something called My Tip Report. It was developed by the Obstetrics Gynecology Foundation for Excellence. So that's where they started, and it was created to collect, use a mobile platform or a desktop to collect milestone assessments, but they really wanted to be in the EPA space. So they partnered with us and allowed us to use it for free as a pilot. And it is very much like Simple. So I agree wholeheartedly with George that the collection of the assessments is not a problem. It was very easy to get people to put this